en vivo, vamos a tener la grabación posteriormente y por favor, todos los que se han conectado y que no ven a sus compañeros conectados, por favor, pasar la voz. Ya le hemos enviado nuevamente el enlace esta mañana. Todavía nos falta que se conecten algunos participantes de la lista de las delegaciones de sus países. Si tienen alguna pregunta, recuerden parte inferior del menú y si quieren dejar un saludo, decir de qué país nos están escribiendo, cuál es su cargo o su rol, lo pueden hacer directamente en el chat. Bienvenidos a todos y éxitos para nuestro primer día de taller. Adelante, Pedro.
Muchísimas gracias, Jenny. Buenos días a todos, buenos días, colegas. Muchas gracias de nuevo por estar con nosotros en este taller de HAR en las Américas, dedicado al tema de mejoría continua de la calidad y a la evaluación del desempeño de HAR, de la implementación de HAR en nuestra región durante el año.
And we will be discussing the implementation of the correlated programs for this year. First and foremost, before I move on to the objectives for today's session, we have some issues with our main speaker today, but first I'd like to introduce Dr. Anselm Hennis. And if we'd like to ask Dr. Hennis to open his camera. He is the director of the Department of Non-Communicable Diseases and Mental Health at the Pan American Health Organization, and he will be discussing and introducing this workshop related to the new PAHO initiative for non-communicable diseases, which is entitled Better Care for NCDs, the new PAHO initiative. Dr. Hennis, the floor is yours. Dr. Hennis, if you please.
Good morning, one and all. Thank you so much for that introduction, Pedro. And so perhaps I can have the slides. Can I have my slides? I think Jenny has them.
Sí, Jenny las tiene. No se preocupe, Jenny las tiene.
Yes, don't worry, Jenny does have them. Dr. Hennis, we are currently in the regional workshop. We have delegations from all countries that are currently implementing the HEARTS program. We have more than 115 people joining us today for this workshop. And it's really comforting to know that this has garnered so much attention in the different countries. And of course, it's important for you as director of the department to be able to address this group, to explain what this new initiative for NCDs is all about, and how HEARTS will be an important component of this initiative in our region. So please, can we share the slides for Dr. Hennis? Jenny, if you please. Forgive me, I don't have the slides.
So it is, Jenny doesn't have them as yet.
Not yet. No, not yet, Dr. Hennis. Not yet.
No, I don't have it. No.
Not
Okay.
yet.
Does Rosanna have it as yet?
Entonces, hagamos una cosa en lo que ustedes se ponen de acuerdo. Pueden ponerse.
Let's do something while you three can work this all out. You can perhaps talk to each other in the chat room, and addressing the rest of the colleagues. I would like to, oh, now we have the slides. Now we have the slides for you, Dr. Hennis.
It's on the right. Good, wonderful. So can we all see it now? Is it on slideshow? Good. Okay. So thank you so much, everyone. Apologies for the technical problem. So really, this is about accelerating actions in primary health care, which is a new initiative of the director of the Pan American Health Organization. As you know, the WHO has a model for care for NCDs, which includes cancers that can be screened for in primary health care, screened and managed, which includes cervical cancer and prevented, as well as screening for breast cancer. Then, of course, chronic respiratory diseases is also included. And as you may know, as many as 15% of our young people have asthma in the region of the Americas. Then, of course, there's health education, health promotion, and you see the issues of cardiovascular risk assessment, management, hypertension management, which really is the core for hearts. And the component also of management of diabetes is really the basis of the D module for hearts. So this is really building on the work that's been done in the region on hearts today and expanding to include other illnesses. Now, the procedure that we're developing is based on the service delivery component of primary healthcare assessment. And it really depends on a number of processes, which is integrated people-centered care, systems for improving quality, resilient health facilities and services as the processes, and the outputs really of the health system are to increase accessibility and availability and ultimately quality healthcare, which improves the first contact accessibility, brings more people into the health system, continuity across the life course, comprehensiveness, people-centeredness, effectiveness, safety, efficiency, timeliness. And these are all issues which are also underpinning hearts itself. So it's really expanding the quality of care delivery in the primary healthcare system. So in terms of what is being achieved, sorry, I went back one slide. In terms of, in terms of what's being achieved, here we are. The idea is in terms of strengthening the integration of entities into primary healthcare. And the reality is this, that entities are already being included as a component of primary healthcare. But here's the challenge. Within the region of the Americas, a third of premature mortality is seen in NCDs. Also, 80% of overall mortality is due to NCDs. So there's tremendous opportunity to improve the quality of NCD care. And this is what this initiative proposes to do. So it is going to increase NCD screening, diagnosis, treatment, and monitoring, integrating them into the health system in an equitable manner at all levels of the healthcare system, particularly with a focus on primary healthcare, as well as prioritizing an equity approach. The initiative plans to address care delivery at the territorial level to address gaps in coverage, access, and quality. And as we all know, there are divides in terms of primary healthcare. There are the rural divide where people don't get access compared to urban areas. There are people who belong to underserved populations who don't have access to care. So the whole idea is to have greater access, accessibility, and equity, as well as improving quality of care delivery for primary healthcare for NCDs. So the initiative hopes to expand equitable access of integrated and comprehensive NCD services within primary care, ultimately with the objectives of improving and implementing comprehensive NCD services, increasing the capacity of primary care services to deliver comprehensive quality care, and strengthening data collection and monitoring, which is a major gap in the region still. There are 6 pillars, and I'll go through the 6 pillars in some details. I won't dwell on it here, but really the first pillar is country plans, which is a joint PAHO country assessment of the gaps and the needs to strengthen care delivery at primary health care, and then develop a roadmap to scale up the plans to strengthen quality care. We are working on developing a primary healthcare assessment tool for NCDs to look at the gaps and priority setting, and then to implement a roadmap. So that is component number 1. Component number 2 is really addressing social determinants of health, because there are many people who don't have access to care. These are the people who are most vulnerable. And we've learned many lessons about this group from the COVID pandemic. So therefore, the proposal is to work with member states and at the territorial level and subnational level to improve contact to health services, adherence treatment, effectiveness of interventions, and improve equity by really trying to focus on those who are most vulnerable. The third element is that of strengthening normative guidance. Now, as I said in my first slide, this really has been developed from the WHO package of essential NCD interventions, of which HEARTS has evolved, as well as the module. And what we did when we reviewed it is that there are over 300 recommendations in PEN. And of the 300 recommendations, over half really need to be updated to current best evidence and multidisciplinary approaches. So if we began working on that in terms of updating the management information and guidance for diabetes, and then creating a living document. And this is something that we're doing programmatically at PAHO across the departments. Then the fourth pillar is workforce development, health workforce development. So we're working on developing a workforce planning tool, as well as training and mentorship through the virtual camps in public health. You can see there are 3 clinical tracks. There are 3 tracks. One is a clinical track, which includes the diagnosis and management of hypertension, and that's in black highlight. Then there's a public health track, and the black highlight, as before, shows the areas that we've already completed. And the third track is data and monitoring. The areas that you see in blue are yet to be developed in terms of the training program. So there's a lot of work for us to do. The fourth component is the regional revolving funds of PAHO. And the idea is to now increase the uptake at country level for the products for NCDs. And as you can see, we have it grouped as cardiovascular diseases, diabetes, asthma, cervical screening. And you will notice on the cardiovascular diseases that it includes medications that are used in hearts, as well as to work on validated blood pressure measurement devices. That's been a strong focus on hearts. So the idea is to build this and scale up, also include other topics, for example, for diabetes care, among others. So this is also part of what we hope to achieve. Then the 6th component is strengthening information systems. And this has many components. And this is one of the priorities of the organization, information systems for health, as well as digital tools. So this allows communications between providers from remote areas to central areas to improve care and to consult, enabling tools through shared electronic health records, disease registries, connections with between providers and healthcare users, and then apps to enable self-care and health promotion. So this is the 6th component of the initiative. So you'll see then there are inputs, which is the standardized guidelines, protocols, care pathways, core medicines and technologies, and also primary care workforce development. The outputs then will be improved assessment of cardiovascular risk, which is a key element of hearts, the management of hypertension improvements, as well as asthma, improvement of pharmacological treatment, and there are many lessons that we can learn from hearts, and then improved diagnosis and management of all the major NCDs with timely referral. And the outcomes are improved blood pressure control, blood sugar control, reduced complications, improved asthma control, decreased emergency visits, screening for breast, cervical, and colorectal cancer. And colorectal cancer is not yet on the agenda, but we hope to include this because this saves lives. Referral for cancer diagnosis and treatment, and ultimately achievement of the Sustainable Development Goals 3.4, which is a reduction of premature mortality for NCDs by 1/3 by 2030, and universal health coverage, which is goal 3.8. Where are we now? So we started into programmatic work. We're developing the tools. We're recruiting someone to lead the initiative at PAHO level. The initiative was launched at the Directing Council in end of September. And then we're having briefings with our country representatives. We're developing the governance indicators and monitorings, and working on joint missions and working on relationships with partners, including the international banks and WHO. So therefore, we know that action to address NCDs is a key priority in all countries of the region. Don't forget that NCDs are the major cause of premature death and burden of suffering and disability. This approach to the primary healthcare is a principal mechanism to support countries in addressing NCD needs based on country priorities. It's an interprogrammatic effort at level of regional office of PAHO. It's building a work that already exists through HEARTS, through the Universal Health Coverage Partnership Initiative, as well as operational planning. Our representatives will be key to lead initiative at country level, and then clearly there are other organizational issues that are going to be very relevant. So I think this is just the documents that we've produced, and I'm going to stop here.
Muchas gracias, doctor Genis, por
Thank you very much, Dr. Hennis,
su presentación
for your
de esta
presentation
iniciativa
of this
mejoría
initiative
de los cuidados de las enfermedades crónicas
related to
y la
chronic
importancia que
disease
tiene la
care
atención primaria, la
and
integración
the
de estos
importance of
componentes.
primary health care.
Para su despedida, doctor Genis, si usted tuviera que
And Dr.
pasarle
Hennis,
un mensaje
if
clave
you had one
a
key
los
message to
países
pass along
que han
to
estado
all of the member
implementando HART,
countries
que
that
usted
are
sabe que
currently
son
implementing
33
the HARTS program,
países
as
en
you
este
know,
momento
we have 23 countries
comprometidos
who
con la
have
implementación de
demonstrated
HART.
a commitment to
Los
the
países
implementation
están
of
en
the HARTS
diferentes
program.
niveles de
These
implementación,
countries
pero si
are
usted tuviera que
at
pasarle un
various
mensaje
stages
clave,
of implementation,
una
but if you had a
recomendación
key
clave,
message for them, a key
una
recommendation
dirección clave,
or a key
¿qué recomendación
directive
usted
for
le
them,
daría a los países
what
HART que están
recommendations can
escuchando
you
su
give to
presentación
these
en este
countries
momento? ¿Cómo
based
HART
on
puede
your
contribuir
presentation today?
activamente
How can
a
HARTS
esta iniciativa?
contribute to their implementation of the initiative?
Yes, well, certainly, HARTS has been the tip of the spear. Hypertension is the major driver of cardiovascular diseases. And we all know that by improving blood pressure control, we can reduce mortality. And we then know too that the other element too is that people have multimorbidities with other comorbidities. So quite often hypertension will not exist in isolation. Hypertension will be part of the metabolic syndrome linked to obesity, high cholesterol, diabetes, etc. So I think, the message I have here now is it is important to continue to work on HARTS to improve coverage and control. So critical that we continue to scale up the implementation of HARTS and using the structures and infrastructures built, the training, the lessons learned. This then allows us to scale it up from HARTS to include other diseases that are also key causes of premature mortality and morbidity in the region, so that we can have a comprehensive package at primary health care, which is built on the evidence and the experiences of HARTS, so that we end up reducing premature mortality in the region and achieving the sustainable development goals that we all aim to achieve. Thank you.
Muchas gracias, doctor Genis.
Thank you very much, Dr. Hennis. We are very grateful to you for your explanation and for your direction and guidance with regard to these initiatives and the objectives of the organizations and the manner in which PAHO is supporting the countries. I was recently at I know you are currently at the PAHO managers meetings, but we really want to thank you for setting aside some time to join us today in this forum. We now have 150 plus people from different countries joining us today for today's session. Thank you very much, and I bid you a very good day.
Thank you so much. It's a pleasure to be here. Sorry I have to run now, but all the best and best wishes for a successful meeting. Thank you.
Bueno, colegas, entonces, muchas
Very
gracias.
well, colleagues. Thank you very much. After this presentation, we're going to go back to the agenda that you all received and that we circulated. And I'd like to ask all my colleagues who are in the chat and that are joining us today, if you have the agenda, I'd like for you to do us a favor and share it with your colleagues that don't have the agenda. First, I'd like to talk about the countries represented during today's session. It's important for us to all be here, especially those who need to be here. We are very encouraged by the massive participation by the various countries, and we have participants from almost every location. I'm not going to delve very deeply into the list, but it would be wonderful if you could indicate in the chat which country you are joining us from and what your role is. For example, I see here Chile, Dominican Republic, El Salvador, Panama, Bolivia, Suriname. And well, I could continue reading off the names, but let's go back to the agenda. We have 2 days of intense meetings. The first day today will be more of an informative rather format. And we're going to be talking about continuous quality improvement. And on day 2, we will have a greater opportunity to hear from the countries themselves. And the agenda is actually quite broad for tomorrow, but we will be focusing primarily on resources and methodologies that we are currently using. I can't see everybody in the chat, obviously, but somebody told me that we had the pleasure and the privilege of having our colleagues from Visol to Save Life. As you all know, Visol is one of our main partners for Hearts in the Americas, and I was told that Rina was here with us, but I'm not sure if Rina is in fact with us today. But Rina is in charge of managing quality improvement, and I'd like to extend greetings to our colleagues at Visol. We also have colleagues from other departments. We also had PAHO surveillance and monitoring staff. And for today's agenda, we will cover the following topics. We are going to start with the ABCs of quality improvement. That'll be the first block that we will be discussing. And the idea would be for us to go over the main topics. So Angelo Gamarra will be coordinating this meeting. I will now yield the floor to you. And as the various countries introduce themselves, we can point out their participation, and we're just going to go back to our agenda. Again, we just placed the agenda in the chat for those of you who may not have it. It's both in English and in Spanish. Again, today's first day of activities is primarily informative in nature. Thank you, Pedro. Good morning to everyone, and welcome once again to this continuous quality improvement session for the Hearts program. Now we're going to go into the actual content that we have set aside for today. We're going to talk about the basic components for the Hearts quality improvement program. So we're going to conduct a panel with the Hearts team here in the Americas. First, we'd like to present the program components, which is something that Pedro will be discussing. Then I'll come in and talk to you about a recently developed document that we refer to as the Hearts quality document that I will discuss in greater detail. Then we will move on to a description of the clinical instruments that will be discussed by Andres Angelo. Let me just say one thing. Today, we are launching 2 new documents. And these are 2 new documents that you all will have very soon. These 2 documents are seeing the light of day for the first time today. One is involving quality improvement, and the second one is the compendium of tools. One is the continuous quality improvement document. This is something that was managed by Angelo and Andres with Harry's team and the various consultants from the various countries. And we also have the summary document that is the compendium of tools. So we have 2 hot topics on the table, and this is the first bit of information that we wanted to share with you. We will be discussing these 2 new documents that will serve as guidelines for the upcoming work. Go ahead. Yes, and just getting back to today's dynamic, and in particular tomorrow, it's going to be more in a conversation format. So the idea behind this is to attract active participation by all of the people joining us today and tomorrow. So as Pedro stated, we have today's activities divided into 2 components. First, the program components. Pedro will be discussing those with us. Yes, and in fact, I need somebody to help me with the slides. Yes, we can ask the team members to support Pedro by showing or sharing his presentation and moving the slides. And subsequently, I will give you a description of the quality improvement document. I don't want to take up too much time, but this is a document that not stem from the team's imagination, but rather is a product of the interaction that we've had with the different countries and the discussions that we've had over time about the various gaps that exist in all the countries. So the focus there is highly concentrated on the pragmatic elements that could be very useful for healthcare facilities in different countries and that could be very useful in every different area in the Americas. So let's get back to quality improvement and the four main steps that are well known. And we want to discuss the specifics within the context of the HEART program. After the break, we will talk about the key drivers. Andres will take charge of that segment, that we're going to give you some practical examples and how we've used these drivers in Chile. And Eric Zúñiga will talk to us about that. And finally, we will discuss quality audits, the importance of collecting data and using data and collecting evidence, not just for reporting purposes, but to also assess the quality of the services that are delivered at the primary point of care. So with this, we will yield the floor to Pedro, and we will get started with the program components.
Thank you. Yes, just like in any project, we have to start with the beginning. Thank you. Here we have a slide. The next one, please. There. HEART doesn't work in a vacuum. There's a set of attributes that makes this program amenable to establishment within a program. And then this is important for the managers of HEART. Here we have all the coordinators of HEART in the region. There are 33 countries committed to the implementation of HEART, and in some countries, they have invited the departmental and local teams to participate in this panel. If you have not done so, please go ahead and spread the word. So what are the attributes to establish a successful program? So let's begin. The first one, we need bold leadership with a sense of urgency to drive change, particularly in primary healthcare settings. That is, we have to identify the leadership. This is essential. This is elementary to advance. This is a program, as you have heard me say, this program is based in new ideas, not just in the traditional settings. So we have to work with the places that have the proper leadership to be able to advance, because that way we're able to give a sense of urgency. And this is what we need to drive change. We need to propose change, to be able to follow up on the different cardiovascular events that happen. Another important thing is a basic infrastructure. People have to trust this infrastructure. It has to be accessible. And it could be cost-free. We hope so. We hope it is cost-free at the time of point of care. So this is key. And then what happens here is that if we want to introduce HEART into primary health care, the different primary health care settings, and they don't have minimal standards or minimal capabilities, The main thing is that people trust the system because people want to go to the hospitals because not only to receive care, but because the conditions in hospitals are better than in the primary healthcare settings. So we have a basic structure to build trust. And then, regrettably, in some primary healthcare settings, people really do not have enough trust in them. The other basic element is that once we start talking about hearts, we have to guarantee a basic set of affordable quality medications and devices and equipment that are available to the program. So it is important in the programming phase to ensure that essential medicines are available for everybody. They are high quality medicines, and we have to have permanent availability. What happens at the primary health care center is that many times the doctors do not have these medicines available at the primary health care centers. So we have to make sure that the health authorities are committed at the national level to make sure that there's availability of these medicines and that these medicines are accessible, free of cost to the population. So many times we have discussed this, and in Hearts we have the tradition of implementation of good program results because most units that have the Hearts medicine that have the proper devices. Remember this, less than 20% of the manometers that we have in the market have been validated. So how are we going to trust people to give us a diagnosis if they don't have the proper devices? And how can we use blood pressure medicine or aneroid equipment if we do not have the proper training or the proper trained staff? So this is another one of the main elements. The workforce should be motivated, should be properly trained, and then it should have enough compensation or salary that is high enough for their jobs. So we have to have a program available to be able to create the capabilities so that we have proper, timely, and efficient mechanism to be able to detect, to diagnose, and to monitor people with hypertension. When we go to Hearts and the clinical elements, we have to see that Hearts is not only for hypertension, it is the gateway. Hypertension is the gateway, but Heart includes much more. It's just the gateway to other diseases. So one of the important attributes of the program is to have a clinically validated blood pressure medicine devices, to have monitoring systems to allow for the evaluation of the performance of the program. In addition to the main attributes, I will not dwell on this too much, but just to mention, in some countries, there has been an excuse or a doubt when applying Hearts to chronic diseases. Hearts is really the practical application of a model for chronic diseases and not only for hypertension, for other cardiovascular diseases. You already know this well. Here, we, in many cases, do not have a culture trying to study these diseases. So this is a model there's no contradiction when we try to include hearts within the methodological framework for chronic disease care. So this is perfectly adjusted to the care of chronic disease care. We want to tell you we're not really inventing the wheel again. We're trying to add content to a model that is just too theoretical in nature. So the other important element when we go to quality improvement, we have to see that there are general foundations for quality improvement. However, when we have a problem, we have to define the problem clearly. We cannot talk about a program of quality improvement without having concrete points. So what are the key questions that we have when we try to implement the quality improvement model? Specifically, just for implementation purposes. So the key question, what are we trying to achieve? That is key. That's the key question. What am I trying to do? What are my objectives and goals? We have to define those objectives and goals. That's a requirement. We have to have an objective. It has to be a measurable objective. It has to be attainable. So in the case of the program, in hearts, the objective would be to increase hypertension control in the adult population, as older than 18, older than 20, depending on the policies of each country, in the catchment area of the health center for X year. So I would like to insist on this. The management of quality improvement is not a matter to take that the Ministry of Health takes care of. It's just the program that is implementing this program. And I would like to mention that this is a format that you can reproduce through training in the different primary health care centers. So this program is not a program for the super administrative structure of the Ministry of Health. This is a program for the primary health care center, and we understand that as a center that exists in the community with the responsibility of a specific territory, and then with health staff that knows the health situation in a different area. So we depend on that. So first of all, I have to actually map that territory to be able to guarantee the understanding of this. And the second key question, we not only include the objectives and the goals and the hypertensive individuals of so much and so much, but we have to also control hypertension in people already being treated. If we don't assign a figure to this, we do not know exactly what we have done. So how do we begin this? We have to define the objectives and goals in a clear way. Second place, what are the changes that I should make to be able to attain these results? If I continue to do things in a traditional way, I will have traditional results. But here we're trying to change. What do I have to change? In hearts, we have clearly defined two indicators. One is the Hearts Performance Index for the new countries. We will be explaining this in detail. And the other is the Hearts Maturity Index. If we only center saying, we want to improve culture, we want to improve control. So most likely, the figures will be just what we imagine. We cannot invent these figures. So for that reason, we have to be extremely careful with the elements of the process. And the elements of the process are the impellers of this process for hypertension. That's what we call the heart. And here are the main results. So it is very difficult to have good indicators of coverage, understood as the percentage of people who have received hypertensive treatment based on the best estimate of hypertension levels. And it's very important to understand this. So what are the changes? What in this case? The changes have been defined. What are the most successful systems in this field? Let us not only think of improving hypertension control, but that we have to improve hypertension in an entire community, region, or country. So we have to really be clear as to what we want to change, where we want to go. How do we know that these changes will result in an improvement? If we do not have the measurements, we cannot know exactly what changes will result in an improvement. So once we determine there's an improvement, we can implement recommendations for the impellers of the hypertension control. And then here is a pragmatic topic. And this is opening the door to the next panelist. When we're talking about Health Center Quality Committee, health centers are the special points where we begin to create this. We have to establish a quality committee at each health center, especially at the primary health level. And then the committee formation. We have to ensure that the group is composed of individuals committed to change with technical expertise, knowledge of the program, the context and the local culture, and with the effective capacity to drive and implement changes. This is elementary. If we want to form a quality committee, another thing that is important is that it has to have representatives from the community. Many of these committees leave the community out, and they lose the perspectives of what the patients want and what the community want. So if you have to be centered on the patient, how do we do that if the patients are not participating? So once we have formed a quality committee, then we assign the mission and mandate. We define the standards and goals. We set the corresponding timelines. And then we define the roadmap. So what do? We define the rules and the operating mechanism to make sure that this system performs well. And then we have to ensure that the Health Center Quality Committee knows this. They have to have proper training. They have to have the skills. But we have to establish a training plan. And we are recommending two things. To be sure that the HARTS package is understood. It's important for people to know about the HARTS package. Otherwise, how can they talk about it? And then we have to have the key drivers for improving hypertension control in primary healthcare centers. It is essential that healthcare facility management participates actively and is willing to implement the changes identified by the quality committee. If you have a committee that tells the management of the center, we have to change this practice and this other practice and this other practice, and then that doesn't happen because there's no political will to do that, but the program doesn't work. But the program must be just like any management program, must be ethically responsible, respectful of culture and values, and has to be based on incentives instead of reprimands. So this is another topic that we have to learn. We have to have incentives instead of reprimands. There are some countries that have different types of incentives, but here I would like to ask you to recognize the champions, to make sure that people adhere to this program. And then last but not least, we have to have a situation analysis and establish the baseline. This is going to be a recurring topic. When we talk about the values and the impellers of this program. Right now, we are talking about the formation of the Health Center Quality Committee. With this, I finished this first part, so you can just withdraw this presentation from the screen, and I will close with my conclusions by saying that make sure that HARS doesn't happen in a vacuum, that is not parallel to other healthcare systems. It has to be incorporated. It has to be integrated as part of the changes. And it is very important to have the facilities and the people at the first level of care that are able to generate these changes and to understand what are the changes to be able to modify the situation by repeating our key message. If things continue as they are, we will have the same indicators we always had. And those indicators leave a lot to be desired in most cases. 3%, 30% of hypertension control. That means 70% of people without hypertension control with safe medicines or with safe technologies. So with this, I finish this first part. And now I'll give the floor to Angelo to continue with the main course of the day. So we're going to be talking about the Handbook of Primary Health Care, objectives and content. So the programmatic components mentioned by Pedro are very important. We have to have well-defined goals, a measurement system that is consistent, and the changes development once we have identified the gaps. Thanks, Pedro, for this first part. So now I would like to introduce the next session, which is the quality document that we have for all of you. It is available in English and Spanish. But Pedro, before that, I would like to recognize and actually acknowledge all the messages that have been sent by the people who are here. We have Chile, Argentina, Guyana, El Salvador, Mexico, Belize, Antigua, Bermuda, Costa Rica, Bolivia, Uruguay, Peru, Brazil, Cuba, Dominican Republic, St. Lucia, Barbados, Guatemala, Colombia. And if I have not mentioned one of them, please go ahead and put it in the chat. And then British Virgin Islands also welcome. Now I will be talking about the quality document. Let me share the screen with you. So what Pedro mentioned is the development of a quality document, and this was originated in the perspective of the countries regarding the need to identify gaps in care and to improve what at the end of the day translates into the most important indicators of coverage and control. So what we have here is the presentation of the document, and the main objective of this document, well, actually we can divide it in three parts. The first one is to react and to improve the structural conditions of health services. When we ask, what are the structural conditions? What is the basis for HARTS in this case? So the second point answers this. We are talking about the impellers for hypertension control. And we will be talking about these impellers. But when we talk about HARTS quality, we're talking about the implementation of impellers for hypertension control, basic recommendations based on evidence to be able to improve interventions in different elements, not only regarding operational aspects, but structural aspects and so forth. And the third point is not only the existence of a monitoring and evaluation system, but also the generation of data that makes sense only if the data can be used to improve quality of care. Otherwise, any evidence generated here is wasted, and it doesn't lead to a change in paradigm or to any change to improve the primary healthcare system. And as Pedro mentioned, we have some indices that we will be mentioning today in detail, and it explains the level of maturity for heart evaluation in the health centers and how this is reflected in better performance at the level of coverage and control. So within the framework for reference of the health centers, this is another point that has been mentioned. So if we have to summarize the objectives, we can just say that systematic evaluation, including management and evaluation of impellers, that is the improvement of the HEARTS program. So from now on, we will be developing this idea, not only the impellers and the auditing, quality auditing. We will be talking about also the clinical aspects and the importance of measuring high blood pressure. Cynthia will be talking about it, what courses are available, what resources are available in relation to all of this. And Jenny Rodriguez will be talking about that. So a more detailed description of the content of this document. And as I said, this will be available very soon to all of you. So we have to begin with the essential clinical tools to improve quality. That's what we have done in the first two documents. We have to have a clear, summarized idea of what are the main tools to improve quality. So I will not mention all of this, but we have the clinical way, the training resources, the monitor and evaluation system, and then pharmacological treatment guidelines, hypertension measurements, and so forth. So once we know what are the essential clinical tools to improve quality, we will go into the document, what Pedro mentioned, which are the programmatic components to improve quality. What are the attributes? Pedro has already mentioned the importance of having a health center quality committee, heart evaluators that could actually activate the program at the levels of the different health care and catchment areas, but also to identify trends, gaps, and patterns that have an action at the level of the ministries of health in the different countries. And that is what we have discussed with you and with the countries. Once we have identified all of these elements, we have the programmatic components, we now have to determine what is the step procedure. We have 4 basic elements here. We can all see these are direct elements. They are very important to put into practice. If we could define a challenge in terms of implementation for continuous improvement, not only conceptualization, but actually implementation, and how to use the existing resources to be able to innovate based on that line and to improve quality. We cannot wait until we solve all the structural challenges or all the problems that we have in terms of information systems to be able to report and use data. The idea is to use what we have at hand. How do we innovate this? How do you restructure the systems so that we can advance? So this is what we are searching in this cycle of quality improvement, starting with planning, knowing where we are as a baseline, then going to implementation, monitoring and evaluation. That is one of the elements that Libardo will be talking about. Not only the evaluation of where we are after a year's work, but the idea is to really understand how are we advancing, how well we are advancing, and then what are the action plans. And then this will be developed later in the presentation, and then systematization of all the changes. We have to learn from our mistakes. We have to learn from the good practices. And here I have to mention that tomorrow we will be devoting all day to know what are the good practices implemented in the region, and you will be developing, talking about your experiences through all of this continuous cycle of quality improvement. And then the other important point has to be with quality auditing. And this is something that accompanies the work of PAHO, monitor and evaluation. So quality auditing is important because what it does is to combine the topic of measurement with learning and planning. This is a collective process that takes place at the health center, and through the development of this exercise, we identify gaps, and then on the spot, we can identify improvement plans. So we will be learning about the experiences in the region, just like in the case of Chile, which is a case that we will see in one moment.
So if we had to summarize the focus of this document, we could say that first and foremost, it's based on the healthcare center. The key central focus is to have the healthcare center as the main axis for this focus, and through the use of the clinical tools that we have in terms of the drivers and the clinical pathways and the resources that we have available for education efforts, as well as the IT resources that we offer, or that many countries already have to be able to monitor and report and analyze data, to be able to generate this quality cycle that we have here, which involves planning, acting, assessing, and systemizing. And this is a cycle that allows us to identify improvements, gaps, and then it just follows through and continues with the process. All of this with the idea of having higher levels of coverage and control. So this summarizes the focus of the document. Now, what we'd like to do now for the rest of the day and tomorrow is to unpack these ideas that we presented today with the help of all of the colleagues. And now what I'd like to do is yield the floor to Andres Rosende, who will talk to us about some of the clinical elements. Pedro, did you have something else? Yes, I wanted to emphasize something else because I see that people keep logging into the session all the time, and I'd like you to look at this format or follow this format. We are recording this to be able to share the recording at a later time with other people. Many of the resources that we will be developing for the future will be based on this model. Now, what I'd like to ask you is how can you position yourselves to undertake this training? And we're just going to be focusing on the key elements, but you're talking, or really what I'm asking is how you will position yourselves to get the more detailed training to be able to implement these measures in your healthcare centers. And I'm talking about clinical tools. Now, this is not something that lies in the Ministry of Health. This needs to be at the forefront of everything you do. It's like what we've done with the data. If the healthcare center doesn't have the data to manage their program properly, then they can't move a single foot forward in terms of progressing towards some objective. So I'd like to tell all the countries that are joining us today to start thinking about this. I know many of you are meeting with other people at the same location and joining us, say, from El Salvador, for example. But I want you to think about what you can do to ensure that the primary healthcare centers, which are the foundation of the HEARTS program, to position themselves to get this training and implement these resources. That's why, Angelo, I don't want to say this is the methodology for quality improvement. That's not the case. These are merely the building blocks, the essential elements required by all healthcare centers to be able to understand the program. So if somebody comes in and says, I don't have a single clue how many hypertension patients I have in my region or in my community, if I have no idea what my coverage population is and what percentage of that has high blood pressure, what percentage has other illnesses. And so if I don't have this data set for my patients, then I have no idea which program to implement. If I don't have any idea what the indicators are for my population, then I certainly can't use any key indicators for the processes. And I want this to be very clear. If I don't understand the true nature of my population of patients. If I don't understand what percentage of my patients are hypertension patients, if I don't understand how many people are in that, then there are no programs. The rest really reduces to best intentions, but those are not very effective. So you need to have the capability to be able to collect the information, to analyze it, to use it. Otherwise, we're going to do what we always do. We're going to do some kind of a campaign with a cute slogan, but we're not going to progress at all. And as you stated, the robustness of this begins with the clinical pathways outlined by HEARTS. And Andres, I want you to focus on this. The clinical elements of HEARTS include clinical instruments and at the same time, other types of instruments. Go ahead, Andres. Thank you, Angelo. Thank you very much, Pedro. Very well then. Unfortunately, for today's audience, you're going to have to get 3 presentations from me. So clearly the 3 of them will be interrelated and we'll be adding layer upon layer in a progressive way, showing that the real focus behind HEARTS is really an integrative process and focus. And this is designed to support a continuous improvement or continuous quality improvement methodology. And that's the main reason for this regional workshop. So I wanted to start talking about promoting change. When we are facing a problem, we have a certain tendency, a certain inertia to want to just jump in and make changes to get out of this problem. So what we really need is to ask ourselves the following questions. Where are we? Secondly, where do we want to go? Third, what are the key actions to be implemented? And lastly, what tools are we going to use to be able to carry out these actions? And it's no coincidence that those of us that engage in any kind of planning, such as climbing a mountain, if we go back to this analogy, this is what allows us to move forward, to improve. This is the foundation of continuous quality improvement. And it's very important that we maintain a certain coherence between our action plans, the planned actions, how the implementation will take place, and what tools we will be availing ourselves of to carry out the implementation. First question, where are we? And this is valid for healthcare officials addressing main causes of mortality, what's happening with the diagnostic, treatment, and control of hypertension, that there are other questions that primary healthcare teams need to be asking themselves. How many hypertensive patients do I have in my community? How many diabetics do I have? How many have come to the center? What's the treatment or the care afforded to these patients? Are we controlling adequately their diseases? Are we trying to address any kidney disease impacts and so on? This moves us to another different type of analysis, which is the second question. Where do we want to go? If we were to set for ourselves a goal of 80% of diagnosis among hypertensives and treat 80% of all of the patients that we diagnose and control 80% of all of those that actually receive care, this will put us at a control rate slightly above 50%, when at the present time it's closer to 20+%. So what's the impact of hypertension? For every 1% increase in control of hypertension at the population level, we can expect a reduction of almost 3% in mortality rates due to ischemic heart disease and almost 2.5% reduction in the stroke mortality rate. Additionally, we would also have to include all non-fatal events that could be avoided. So any patients that have a coronary incident or a stroke, that doesn't die. So we're talking about 5 to 7 events for each death. So the impact is extremely important. But we cannot just focus on hypertension, as Pedro was saying. Yes, of course, we need to understand and address hypertension, but what are the concrete elements and drivers necessary to control these diseases? So we have here 17 recommendations, evidence-based recommendations that will allow us to reach the top of the mountain. So we need to improve the condition and the tools for our patients. And what are the clinical tools that will allow us to mobilize these interventions? Later on, we will be presenting this document mentioned by Pedro, the Essential Tools Compendium, and it's formatted in a very graphic, very visual way. All of the tools outlined in this document are extremely well explained and explained very clearly. I'm showing you just 3 here. First, we need to focus on the clinic itself because that's where they analyze the implementation strategy. They also execute the correct protocol for measuring hypertension. If this is a severe case, we can't just continue to measure this variable blood pressure or hypertension level that cannot be substantiated by clinical validation without standardized healthcare protocols. And lastly, how can I monitor all of the interventions, all of these procedures that we are conducting in healthcare facilities to improve the quality of life for our patients if we don't have the data, if we don't understand the variables to improve the processes, improve the assessments, then we won't be able to develop the necessary policies. We will never know whether or not we are performing better or worse. We will basically find ourselves in the same place where we began. So this is something that focuses directly on healthcare centers, and we can see how within this compendium, we include certain essential services that are provided at healthcare centers. Now, when we talk about quality improvement process, we have 4 phases: planning, action, assessment of the impact of our interventions, and systematize the change. Now, if we look at this from a 3-dimensional standpoint, you can see it in this way. Every time we implement a cycle, we take a step up towards our goal. We move closer to the top of the mountain. Then from there, we start the cycle again to continue that improvement process and bring about those changes that will allow us to bring about real impact in the health of our population. Angelo. Thank you very much, Andres. Go ahead, Pedro. No, that's wonderful. I think that we need to add another element. Now, we can talk about general terms, and I believe that this is a topic that we will delve into much more deeply tomorrow, Angelo. But hearts can't go to the margins of what's happening in the healthcare system, nor should it become an isolated element that contributes to the transformation of the system. But hearts can help move the situation forward. It can help open roads, especially in cases where there is no road or the road isn't wide enough. Clearly, if you have a containment rate of 80%, then congratulations. And you can maybe share with us how you're bringing about that result. That would be the other issue. There's no mandate that says this is the recipe that you have to follow mandatorily. What we're trying to do is this may be, or this is the best evidence, but somebody else might have even better evidence than what we're offering. So I think that we need to be respectful of the local culture. We need to be respectful of local values. We need to understand the local system as well, but we can't stop doing what the science tells us. So if we say tomorrow, Andres, you need to implement the clinical pathway for hearts, but if we don't provide the tools or the conditions to do so, it's not going to happen on the ground. I would ask our colleagues that are listening to us today, because Zoom does have that limitation. We can't open or enable the microphones for all of the people joining us, but you could also submit any questions or comments through the chat room, and we can try to answer them, or through the Q&A room before we delve more deeply into other topics that we have on the agenda. Again, think about the first primary healthcare point of service. What's happening with the care? Andres, you already said it, but I want to reiterate, we have two new documents. The one that was presented by Angelo related to continuous quality improvement. And we also have another document that involves a compendium of tools that Andres will be addressing throughout the course of this workshop. And in a single document, we summarize, and by the way, this is in digitized format. It summarizes all of the clinical tools that we have available. So I'm looking at the Q&A or the chat, but I don't see any questions or specific question about what we're talking about. If there are none, then we're fine. We're right on time, and we will continue with the agenda. Andres, there's another topic that we've been working on with the HEARTS program that I'd like you to address. I know that you may have planned to discuss it later, but how is the clinical pathway developed by HEARTS, which is basically a standard, allowing countries to adopt this type of intervention instrument? And how do HEARTS clinical pathways in the different countries allow them to bring about more control over their processes? Because previously it was complete anarchy. And how do these protocols help to bring some order to the chaos? Very good. Getting back to the clinical pathways a little bit later, Pedro, what you're saying is actually very true. The concept behind the clinical pathways and how countries have adopted these to gain better control of their cardiovascular patients have brought a great deal of coherence to the care provided in those countries. To this day, the care provided to hypertension patients still has quite a bit of variability, and many authorities the world over are calling for greater coherence, because we are far removed from where we want to be, not just with regards to coverage rates or control rates. We still have extremely low rates of success, even in high-earning countries. And through HEARTS in the Americas, we've been able to achieve a consensus that includes 33 countries. Not all of them have the clinical pathways in place, but many of them have several already in effect. And we do have to face the reality that some countries have access to better medications, other countries have better access to clinical resources, but given the variability that existed previously among all countries, we've been able to reduce this and mitigate this in a substantial way. And we expect to be able to reduce this variability in the near term much more. So this is part of the objective of improving the management for these cardiovascular cases. Andres, you know that the clinical pathways offered by HEARTS offer advantages for healthcare systems, for providers of healthcare services, healthcare teams, and it also offers advantages for patients. So it's a three-dimensional tool for a healthcare system. If they ask you, what are the advantages of this program? What are the advantages of having a clinical pathway? The pathway in and of itself is insufficient. You need to take the next step, which is to institutionalize the pathway. So if you were to give any advice to those folks who are joining us today, and are listening us today, what are the key elements that the clinical pathway provides for the healthcare system? And I'm just going to offer this up on a platter for you. How does this impact the healthcare system? Now, one country that has been very active in all of this has been the Dominican Republic. And we all know that the Dominican Republic is one of the countries with the highest rates of cardiovascular diseases in the region. And we've seen a severe increase in the mortality for that country. So in the Dominican Republic, they pushed through a complete review of their medication system in their country. They reviewed and revised their medication protocols. I'm serving this up to you on a platter, Andres. Go ahead. Yes, exactly, Pedro. The clinical pathway is a very powerful tool, not just for the healthcare team, but also for managers at the ministerial level or at the direction or directorate level, and above all else, for patients. This is extremely important. If the country adopts a clinical pathway and subsequently institutionalizes the pathway, then they're conveying a very loud message. This is how we do healthcare. In some cases, you have to introduce a perspective related to rights. That is, if I am openly establishing and making available this pathway for primary healthcare attention for cardiovascular patients, then I am building an entire infrastructure behind this. So I need to ensure the proper availability of medication, blood pressure cuffs, and other tools. This brings about other benefits because then if I have a smaller number of pharmacological options, then I can use economies of scale to make larger purchases of a smaller assortment of products and get better prices. So this improves logistics. It avoids bottlenecks in the medication supply chain. It avoids medications expiring on the shelves. So it improves care flows. It prioritizes more frequent consultations for the higher risk patients. And if I introduce or if I make more visible the need to identify the higher risks related to my population, and I improve my healthcare practices at the first point of service, along with all the other elements, then what we have is something that is powerful beyond what we could even imagine in the short term. So we could have a poster on the wall that outlines the treatment, but after a certain interval, Pedro, I'd like to talk a little bit about the drivers for the clinical pathway. We're also going to talk about this other very interesting topic, which is the perspective related to rights and what this can help us bring about in the healthcare arena. Wonderful, Andres. I'd like to ask the countries to comment on this, such as Omelia has. How can we progress with regard to these key concepts through the use of these clinical pathways? It would be interesting to hear from the countries to understand what they're doing with these pathways. I wanted to mention something that is still reiterated in many places and that I want to get back to. The term relates, or the issue of equity is something that we need to come back to. It has consequences from the economic and healthcare standpoint, but with the clinical pathways offered by HARTS, once implemented, they allow the most vulnerable, isolated populations to access a better standard of care. When we go out to those places where they don't have access to medications, when we have populations that go to other locations to get medications where they have insufficient healthcare facilities, insufficient equipment. There's a way to change the narrative here. We need to just not only look at the problems, we need to understand the various frictions that exist in any particular location. And these are quite numerous many times, and that's why we have very high rates of mortality, because we see a great deal of imbalance between lower income populations versus those that are at a higher income level. So these pathways allow us to address all of these things. Our colleague from Chile says the compensation has been much more simple to achieve. The only thing that we have pending as a public healthcare system is that we have combined medications to facilitate adherence or compliance. And this is how you can see how the clinical pathway can lead to another option that can move you forward. So when we achieve this level of compliance or adherence, the pharmacological standard framework shows some evident results. And so when we talk about the ABCs of continuous quality improvement, Angelo will bring us back to the quality cycle. So I'd like to ask everybody to share in the chat any actions that you are observing or executing on the ground in your respective countries for us to have a better idea of what results you're getting in the field. So I'd like to ask people to share their experiences through the chat. Go ahead, Angelo. Thank you, Pedro. Just to elaborate a little bit more on what you said about equity, one of the key elements is to understand where we are, understand our population, and in that sense, bring about a data-based focus to our population. Understanding the different demographics will help us understand the gaps, because the gaps can be cross-cutting, but they can also be focused or centered around certain groups or populations with specific characteristics. And these may pose some more complex challenges. So the more we address these frequent narratives, the better outcomes we will have. So let's go back to the quality cycle topic. What I wanted to mention first is that this is based on 4 key points that I mentioned earlier. The idea is to first understand a planning process. This would be followed by an implementation phase based not only on evidence collected through databases, but with a clear-cut idea and understanding of the available resources. We would then follow that with monitoring and tracking, and then systemize the changes. So this is a general view, but it's important for us to establish this cycle at a minimum, and this is foundational for the HEARTS program. So the 4 steps are the ones that I outlined. Let's start with the planning step. For planning, and you can all see basically the content of the quality improvement document, and we're just showing you some overviews, brief overviews. So firstly, based on what Pedro was talking about in terms of forming a quality committee, in many healthcare centers, they have shortages of human talent, human resources. People are doing several jobs at the same time. And we may have people that say, I've got my plate already full. But the idea would be to identify how a quality issue can, in the medium term, bring about a reduction in the workload for staff that work in healthcare centers. A practical example relates to a visit we made to a location in the region. The data is entered into an IT system, but the data is also recorded on a paper-based system. They have paper records, and when we asked what the reason was for the existence of these 2 systems, we were told that there was no clarity in terms of the sustainability of the IT system. So as a backup, and understandably, healthcare facilities decided to stick with the paper-based system to be able to have a backup in case there was any kind of inconvenience with the IT system. So this made sense, but when we asked, is this increasing the workload? Well, they said yes, but it's got to be done. So this is a gap, and the idea is to develop a system or a way to countermand this type of problem in the medium term could mean a reduction in the workload for a lot of staff in healthcare centers. This is just one example out of thousands, and you can probably share many other experiences or cases that you have observed and where you've identified the need to focus on quality. So a quality committee is a group that can identify these different issues during the day-to-day work and provide a certain context. So when you use the baseline assessment data mentioned by Andres and Pedro, and Andres will delve more deeply into this, the maturity indexes based on the drivers, it'll give you an idea of where you are, what actions you can undertake in the short term, and establish a plan.
The important message here is that we do not have to cover everything at one time. We have to take into consideration what the countries are doing. What are the immediate needs? What is feasible for solution in the short term, and then begin there. So the idea is to study the culture, not only for quality purposes, but also for constant improvement. What are the basic elements to be able to move this wheel? So we have the quality committee that has to be present in the health center. It has to have a meeting of socialization, presentation of the quality committee. It has a proposed plan, definition of quality in this plan, and then the implementation. It could be 1 or 2 years. So tomorrow we will be hearing our colleague who works at PAHO in health quality at the health centers to see what the health center quality plans are more sustainable, if they adhere to national quality policies. So that we will be discussing tomorrow. So planning is very important. Then, what are the steps? We already have the committee. We have this committee that has socialized with other entities. So where are we? We have to have an analysis of data and structure. What are the components for purposes of initial evaluation? Not only the result, but also data and the structure. Those are elements for improvement. So we have to have a detailed review of the 17 recommendations. Those are the drivers. Andres will be talking about this. And then we have to estimate the coverage data. How big is the population we're covering? We discuss this with the health centers. Coverage is important. And then the response is varied because there are many challenges and we do not know all the details of the catchment area. So this is important information that should be associated with the concept of quality gap to see what are the elements that allow us to respond well based on the evaluations that we can conduct at the health system centers. And then we have to know exactly where the health center is located. So for that, evaluation, monitoring and evaluation are important elements. We are not generating a new system. We don't want to duplicate efforts at the level of the health system, but also we have to generate data and to make sure that the health center uses those data. For instance, as Libardo has said, we also have to consider strategies to be able to use the systems existing in the countries to see what are the main reporting and utilization type of efforts for conveying the proper data. So we have to try to identify data and sources of information to be able to report coverage and control. And the work conducted led to a structural and detailed review about the participation of the patients at the health centers, and then that led to an institutional estimate and recommendations to see how we can enter systems and how we can start to improve more structural data. So this is the importance of having an information system and of thinking about the implementation of a quality system with the proper data on risks. We cannot start if we don't know where we are. So we have to determine where we are in terms of structure and control, the processes based on the drivers, and so forth. So that's where we start to move the wheel. I'm just repeating or maybe summarizing what we have said. We have to have a baseline of the maturity index. Maturity index is the metric that define the drivers, and then we have to define the necessary actions at the level of the health center. And then once we identify a group in this health center, what are the national or local actions that we have to undertake, for instance, for blood pressure monitoring. And Silvia will be talking about that. There are many things that go beyond the actual work of the center. We have to consider an aggregate level of care to be able to tackle this quality gap. Obviously, participatory approach is very important. We have to determine what are the relevant changes. There are elements related to pharmacy, how we monitor drug stocks and reserves. And also, this requires participation of the people who are responsible for that part of the program, and their response must be pertinent in this case. We just also have to define the indicators for use of that medicine. And then now we're going to implementation. Here, we have a clear idea of what we have to plan based on the drivers to improve the control of hypertension and coverage of hypertension. We have defined these parts as actions to close these gaps. Here, the drivers are the main elements. They will lead to actions for implementation. And then we have to monitor, document, and evaluate the steps. Those are all challenges in advancing. If we do not document the prioritization of drivers and the strategies that we are adopting, if we do not have a documentation process, there's no continuity when new participants are involved. And also very important is a construction of capabilities program. What do we have? What does HARTS have to offer for this? Pedro has mentioned the quality committee will be the first one to absorb and actually put into practice all of these elements. We have taken the concept of trainer of the trainers to this effort to be able to cover a wider group. Also, we have to have effective communication to be able to improve interventions. And then also something that Pedro mentioned is the recognition of champions. We have 240 champions, and these champions are the ones who will be able to take this approach to their colleagues and their peers. So in monitoring and evaluation, I will not dwell on that too much, but those activities are based in health centers. This is not just a reporting system. And it will be successful if the health centers who generate the data are the main consumers of the data. If we have that, then the monitoring and evaluation effort will be successful. We have to have all the indicators aligned with the programmatic priorities. We have to actually order our ideas to see how we are going to go. And for that, we have these modules of structure, processes, and results. And throughout the logical hearts model, we will be able to identify our progress and then measure the maturity index for implementation and for performance. We are not just reporting. We are using something that is instrumental for the process of continuous quality improvement. For instance, in El Salvador, they have used the monitoring effort of hearts. Dr. Matias Villatoro told us about 8 steps that they have taken in this effort. So the systematization of change is mentioned by Andres. We monitor, evaluate, and act in many places, not only in one place. If we have achievements, maybe we can go back. And for that reason, we have to be very careful when we plan. We will see a case associated with this quality auditing. Erica mentioned the visit to the centers and how they have been able to improve and continue the spiral. So all of this is targeted to quality auditing. I will not stop too long here because Eric will be talking about this, but all of this is complementary to this effort because this allows to have an external look, partial and objective evaluation of what is being reported by the health centers and the actions that have been implemented. Not auditing as a vertical effort, but as a space for collective learning on both sides. For instance, the health center can see the gaps, can see the limitations for improvement, but also the people who perform the auditing learn about the field experiences to be able to take this knowledge to other spaces and to be able to work in a more open and complete way to find other elements. So this is important. Auditing is central, essential to these practices to be able to reduce or to close the gaps in quality. So this is what the cycle of quality improvement entails, and we will be talking about this more extensively. Pedro, we have some comments in the chat. Yes, Angelo, thank you. Yes, the important thing is to make sure that what we're talking about right now is that we have to implement a systematic group of interventions. We are not just moving our fingers and saying one word in a discourse. No, in a speech. No, because nobody will believe us. Nobody will follow our measures. If we say, yes, we have this in control, but we don't say how we attain that control. So what we have to have clear steps. And I have asked my colleagues to share by chat their reactions. And we have really interesting reaction. For instance, one of the things that Shanna, a tracer from the British Island, is how to make sure that private centers adhere to this. And what I can say is that we have Uruguay, which I visited last week. And then in trying to understand what is going on in Uruguay, they already are working in public and private facilities. They knowing that the Ministry of Health has a real regulation power for this practice. But then we see when a health center does not want to adhere to this, we have to ask for are there indicators. So we have to question people having our data at hand. If we go to the super specialists, we already know this. Ask Natalia Vicentini in Argentina. The specialists many times think that we're disturbing their spaces of work. Natalia says, undoubtedly, the critical way is an essential collective tool, but as also this allows us to be able to meet the increasing demand of resources. It's not only an educational tool for the health system, but also it has to have a health standpoint. Another comment says that we have been working on the clinical ways for diabetes to find tools that establish a dialogue among the parties. So there are many countries that have advanced a lot. I don't know if the Dominican Republic wants to include their clinical ways for diabetes. What we aim at is not to have contradictions. And Anilla Villatoro from El Salvador says that in El Salvador, this allowed the standardization of treatment schedules and to change the level of use of medicines and to be able to determine the one-time dose within the national health system. And also it allowed us, she says, to include these medicines in our list. So as we see, the approach has direct impact in the management of health system. Adriana Pacheco, El Salvador, also says that the clinical way has allowed us to reduce the therapeutic inertia. And then it shows a simple way for generalist doctors to work with this combination of drugs. So I think really, I'm really asking the countries to please just go ahead and put their work. Anais Vasquez says, in Chile, we have been able to demonstrate how this intervention under hearts, another type of treatment, can be understood using referrals to secondary care. So, and this referral is timely. So I think we're just moving to the next level of complexity. We have to remember that this is targeting the general patients, not the exceptional patients. So we allow this to take into consideration, to take the health system into consideration and the patient into consideration. So we have to really think that the drivers of the control of hypertension are the basis for this system. I am not talking about a word taken from in Spanish from English. Some of them says impellers in Spanish and others say drivers. But what I'm saying is, whatever you call them, they are the elements that improve hypertension control. We have to evaluate what works and then to systematize this. So I think in the next round of comments, we should center on the what changes have taken place in the health system. Now we have established a rule. We have systematized the practice. We are including fixed dose combination drugs in the system. So this changes the policy. we had some medicines that had been almost excluded from primary health care because they were at the specialist care. So we didn't have high-intensity statins, didn't have pressure gauges in several countries. So we had to have validated blood pressure gauges. So this is what I call the systematization of practice. We take the studies of hypertension, we evaluate everything. So this is a rule, it is included in resolutions, and then this is established as a better practice for improvement of treatment and care for hypertension. I have the Tomiris again. And Tomiris said, if we have already the clinical gateway for diabetes in the country, and we have strengthened the HEARTS module, and we have now healthy diet, all of these concepts have been institutionalized. And then also Yami Adamis from Panama said also HEART strategy has allowed us to redirect and systematize care. And that Janine Adamis, for a heart worker in Panama, heart specialist in Panama. So I will understand that if you don't write in chat, you don't want to share. Is that right? That we are a community of countries, and obviously we want to share what we're doing and what we're learning. So now we will have a break. It's a 5-minute break. Marcelo is in the production, will be accompanied. It's a physical, what I say is a biological pause to 5 minutes. And we will see you in 5 minutes. Please take a deep breath, change position in your chair, and come back on time.
Marcelo. Estamos regresando a la sala después de una breve pausa. Esperemos que
Okay,
esta pausa
we are back in the room after a brief break. We hope that this has been used to stretch your muscles and to go take care of your basic needs. So now we will continue with our workshop, and I would like to comment that we have a couple of messages from Guatemala. Guatemala is a country that has had difficulty with the implementation of HARTS, but it looks like they are getting on the road now. In Huehuetenango, the HARTS implementation is supporting adequate care for hypertensive patients to be able to increase first level medicines. And in San Marcos, we started the HARTS program with the first training group. I think this is very important for the implementation of our health services. My recommendation is to invite everybody to the workshop because the first level will benefit a lot. Bolivia says that the committee has been formed, and Aura Marina Gomez, I don't know where she's from, but this year, she says, we said in the northern part of Guatemala, we had some problems of budgetary problems, the first level, but now we are taking care of patients in a timely manner. In Ecuador, they are having a HARTS workshop with the delegates of the health system for purposes of expansion. So that's from Ecuador. So without further ado, Andres, are you ready for the first part, which is how we will go? You have to go slowly. Remember, this is the main course of the day. This means which are the main intervention to change the status quo, to change the way in which we practice primary health care to manage cardiovascular risk. Andres, please go ahead. Thank you so much, Pedro. We will go back with the topic of the drivers and the clinical way. And here, the title of my presentation is exactly the key drivers to improve CVD risk management step by step. Going back to Pedro's comment, HART is not a vertical program, focuses on hypertension. Hypertension is the gateway to the program because risk factors, the most prevalent problem in cardiovascular disease. But this has as the first level prevention of kidney disease, management of the health services around the management of non-communicable diseases. And here we have the drivers. As you can see, we have 8 key actions. They have been grouped in 5 areas: diagnosis, treatment, continuity of care, the delivery system, and finally, the performance evaluation and monitoring. So these 8 drivers, each one of them could have 1 or more key interventions for a total of 17 interventions. And here you can read on the screen of this slide. However, if we simply describe these actions, we have a similar situation to what Pedro mentioned about the model for chronic diseases. This is a framework, it's a conceptual framework, but we need to put it into practice. Why? Because we have In addition to the drivers, we have the recommendations based on evidence for the management of drugs for blood pressure and other interventions.
As well as other corresponding treatments, including vaccination and others, very important for cardiovascular disease management. And it's based on certain formats through a treatment protocol. This form that has allowed Kaiser Permanente to implement the most successful cardiovascular intervention program in the world with a very high rate of controlled in their hypertensive patient population. Now, how these three tools are integrated through implementation tools that focus and that prioritize these interventions identified by the drivers as key interventions to improve the quality of care. This is what takes us back to the clinical pathway. For me, it's a real pleasure to read the comments from the different countries with the experience that they've had with these tools, because as I was mentioning earlier, with regard to the clinical pathway, in principle, I could show it to any person that is perhaps unprepared. That's just a poster with a series of recommendations for hypertension management and what have you, and that's as far as it gets. But what we're proposing today is to break this down into its main parts and try to identify those drivers that I showed you in the prior slide. The clinical pathway is divided into three moments. A, linked to diagnostic. B, linked to the categorization of patients based on their cardiovascular risk. And you have to set up the prioritization that is, and C, which encompasses everything having to do with treatment and continuity for care required for those patients. So what we are saying very directly is that we need to measure blood pressure in all adult patients, and we have a driver here. When the devices that you need to use are automated devices that are clinically validated for use on the arm, that's one driver. When you set up a standardized protocol for taking the patient's blood pressure, in which the patient cannot be in any position, sitting on a chair or in the bed with the arm hanging down, with the blood pressure cuff on top of the clothing. That's not going to work. There needs to be a standard in place for all these procedures. When we talk about making sure to understand the cardiovascular risk of patients, you want to take the blood pressure, but the frequency of follow-up and the corresponding treatments are not going to be the same for a patient that has high risk versus one that does not. So there are other drivers at play there. Now, when we say do not delay any pharmacological treatments, don't go out and make all of these changes in their lifestyle that really won't be complied with by patients, then understanding that we need to be aware and conscientious that a very large portion or share of the patients will not come back, and many of them will continue to suffer from hypertension without any control in place. If they do have these symptoms, then we do, of course, need to recommend lifestyle changes. We may have to ask them to change their diets. They need to lose weight. They'll have to reduce their consumption of certain types of foods, many with high salt content or sodium content or fat content. But at the moment of the diagnostic, we have to understand that the reduction of blood pressure avoids the frequency of cardiovascular incidents. So we have another driver here. When we see the cardiovascular risk operating at different thresholds, and when we use that threshold to address which pharmacological approach we will be using, then that's one driver. When we want to engage in control measures in a differentiated way, then we'll be doing that based on certain drivers. When we focus not only on primary care, but also secondary care for patients that have already suffered harm due to atherosclerosis incidents, be it a coronary or some transitory ischemic incident, or they suffer a heart attack, or if they have excessive plaque in their arteries over and above 50%, or if you take urine analysis and there's a high percentage of urea, then these patients will have a much more intensive treatment protocol. For example, aspirin on a daily basis in the secondary stage of care, as well as other protocols. And that's another driver. Now, when we look at another standardized protocol for cardiovascular disease, then the blood pressure is a driver. So when we talk about the first step that we need to take with all patients, we are looking at drivers and we are recommending different alternatives to improve adherence and to mitigate the conditions, and we are basing this on drivers. So if we support through the purchase of certain medications, then we can end monotherapies, because what we will be using instead are combinations of two hypertensive medications. That's what's going to break the cycle. Now, by incorporating these recommendations for a healthier lifestyle from the outset and insisting on extending this over time, contrary to the traditional adherence. First, you recommend a change in lifestyle. I'll see you in 6 months. And in that time frame, they might have had some kind of cardiovascular event. And if we forget about healthy nutrition, a healthy lifestyle, an active lifestyle, then we're not going to be doing anything. So we need to continue supporting these interventions over time. We are defining, or we're not defining these protocols with these 4 steps. We are setting objectives, and we could say, which difficult patient that we can't properly control at the primary care level, we won't be able to see them again for another 4 months, then this is something that, if dealt with properly, will lead to an improvement in the care. We need to address the hypertension issue in a different way. I cannot just rely on a single measurement. We need to incorporate a separate driver, which involves repeated measurements. And we need to use prescribed intervals that have to be followed up on to be able to achieve higher levels of control. So that is also representative of another driver. So again, we had 17 specific recommendations based on the 8 drivers, based on these clinical pathways. Now, when we talk about patients under control, for patients that are not at high risk, that have their hypertensive medication and that are adhering to the protocols and recommendations, then they don't have to go to the healthcare center every couple of weeks. That wouldn't make any sense. That would overload the activity at the facility, and this would be detrimental to patients that do need healthcare in the facilities, and that way they won't have to be put on a waiting list of 4 to 6 months. So the higher risk hypertensives need to be seen more frequently. The low risk hypertensive patients can maintain their medications, their different intervention recommendations, and don't need to be seen with the same frequency. Now, for me to be able to implement this, I need to also use long-term prescriptions. Once we control patients' blood pressure, and once we understand that in order to maintain stability, we're looking at the long term, if we need to, or if we see that the patient will need this treatment in the medium to long term, there's no point in having this patient on a monthly refill prescription. So many times patients cannot miss days of work to be able to go to the healthcare center. Understanding that in the region we have many informal workers who understand that if they don't go to work, A, they don't get paid for that day, and secondly, they might lose their jobs, then they still have to bring home the bread. And that's one reason why we can't really ensure that we can make these people adhere to these different protocols and these frequent visits. So we need to understand the risk level for the patients and then adapt the protocol accordingly. Now, if we have patients with different contagious diseases such as COVID, then we're not going to be telling patients they need to get the flu vaccine because that will mitigate their chance of getting a cold. What we do with the flu vaccine is mitigate some other diseases. And so what happens with people that get colds? Well, they often have respiratory complications and sometimes cardiovascular complications. And this combination can lead to heart attacks. And so patients who are at risk that get into a circumstance that is more complex still due to other situations such as colds, then integrating some control measures for patients of that type is absolutely necessary. The same relates to other diseases that affect high-risk hypertensive patients. And this was a big part of the problem with COVID. Fortunately, the clinical pathway has been very successful, and we see here a combination of different styles whereby each country has adopted the concept and has developed their own clinical protocols based on their directives, based on their implementation strategies, their available resources. And we encourage all countries that have not yet developed their own clinical pathways to continue working on these because they make sense. Now, lastly, why is the clinical pathway so important? When a simple view of this makes us think that it's just a poster on a wall. I think that this could be seen as a very powerful tool for clinical intervention. It doesn't generate any excess workload. If anything, it facilitates the work. That is, it promotes the transfer of competencies in managing patients. It reduces the need of undergoing unnecessary procedures. And in addition to this, it needs to be understood as a prescriptive practice. That is, you need to move forward based on the care model for chronic disease patients, based on the competencies that are in place, and based on a teamwork model. So what does this mean? if a physician has a hypertensive patient and prescribes a number of interventions, we may be able to have a nurse provide the follow-up for the patient, and based on how that patient performs with regard to their cardiovascular and hypertension condition, then we can customize the additional care that will be afforded to that patient. So this will foster better teamwork, and it also makes the practice more efficient, and it minimizes the therapeutic interventions. This is something that's extremely important for the public health arena, and it's been outlined by you in the chat, by many of you. So when we minimize the care, it reduces the workload, it reduces the excessive purchase of medication, it allows for indirect and direct cost savings, and again, it reduces any unnecessary workload or the burden on the healthcare system by prioritizing the key services that these types of patients require in the long term. And the other perspective that we also need to incorporate into all of this, and that is also considered in the pathway, is the community perspective. This is a community tool that, as a patient at a healthcare center, I can see in the form of the rights that I have as a patient, the role that I play in my own care, because I have these rights, because my blood pressure is being measured in the proper way, because I'm being cared for by a team that is prioritizing the key issues that I have. If I have a prescription for a certain medication and I always continue to have blood pressure above the prescribed threshold, then I can submit some form of a claim, or I can complain about not getting the service that I require. And this is something very powerful to involve the patients in their own care, so that in that way they can take ownership in it. So that's all I have for you regarding this, and I'll come back a little bit later. Thank you very much, Andres. As always, very clear and precise in your explanation. I'd like to ask you to stay for a while before I yield the floor to Eric. We've seen some excellent contributions by the various countries. I'd like to read them, and if you have a brief response to any of these, please go ahead and chime in. Again, I want to extend greetings to our colleagues from Venezuela and Panama who are actively participating in the chat. We have a comment from Janit saying that in Colón we conduct workshops on the importance of categorizing patients correctly. Thank you. We also have Daniel from Guyana. We're going to read this in English for our colleagues.
125 facilities, but we have approximately 384, so we haven't reached half of the facilities as of yet. 3 weeks ago, we had a trainer of training workshop with participants from all of our 10 administrative regions. They will go back into their communities and train staff, so we should be able to scale up faster in the upcoming year. Entonces, felicitaciones también al equipo de Guyana. Percy desde Perú nos menciona, en Perú
So congratulations to our colleagues from Guyana. Percy from Peru says, we are aligning the detailed aspects in the clinical pathway with the health care social security payment system. In that way, we also have a follow-up system to the quality protocols. We believe that it's a system that can ensure full compliance and accelerate their implementation. We also have another comment related to the diabetes clinic. There's an interesting name that's being shared by the Dominican Republic. They have strategy for healthy nutrition, and they refer to this program as SALSA. So that's a very saucy, very attractive, interesting term for that program. In Uruguay, there's a standard for prescribing medication for chronic patients. It includes hypertensives and diabetics. Matias from El Salvador says that In the vaccination model in El Salvador, they've incorporated pneumococcus 23 valente for persons with high cardiovascular risk and influenza. Question from Carlos is that what suggestions do you have in case of seeing adverse reactions to any treatment prescribed by the clinical pathway? Well, that's an excellent question. First, when we talk about pharmacovigilance, this is something that we need to do along with any treatment, but we all know that we don't see it often enough. But when we propose this clinical pathway and there's a pharmacovigilance protocol involved, and this sets off alarms because people's fears is that providing more medication may lead to greater frequency and adverse reactions, greater intolerance. And really what happens is the contrary. When we deal with hypertensives, we can use lower dosages because the hypertensive aspects can be empowered and the adverse impacts are independent. When I use monotherapy, for example, and I'm indicating a medication at 50% maximum dosage, and I have a predetermined effect and a predetermined adverse effect that won't be very significant. So we can use monotherapies at maximum dosages. Now, if I have additional risk, cardiovascular risk factors, then we can increase or modulate the dosage and say reduce it to 20%. So what happens with adverse effects is that they double, or in some cases they triple. Now, if instead of that strategy, I combine an antihypertensive at 50% of max, then the adverse the impact on the hypertension side is doubled, but not the adverse effects. So to respond concretely to the question, if someone implements a clinical pathway, I'm going to look for a greater safety profile. I'm going to try to be more efficient with a lesser number of medications. Now, am I going to focus on adverse effects? No, quite the contrary. I need to heed all of the pharmacovigilance elements like I would when using any other medication being employed in the healthcare system, ranging from antibiotics all the way to medication for asthma. Thank you, Andres. And capitalizing on your presence, we have a question from Sebastian Cartagena. According to the guidelines, these are based on controls for every 6 months for a certain cardiovascular risk. But is this something that a physician can handle, or would they need a specialist, say in nutrition or some other field? Well, that's an excellent question. Every 3 to 6 months control, as we stated, is based on a certain cardiovascular risk for the patient. The idea would be to achieve a minimum semblance of control. And if we don't control this with 3 medications, then we might be talking about 5 to 10% of the total patient population. We'd have to refer those patients to the specialist, kidney specialist or what have you. Now, the patients that we are able to control, we can see them every 6 months or every 3 months. These consultations don't necessarily involve a professional or a specialist. This is what they do in many places in the US. And Kaiser stands out as one organization that uses these common practices like other countries do, such as the United Kingdom. Clearly, if the patient under control is taking their medication, there's no adverse effects. And I go back to pharmacovigilance. They have their blood pressure controlled, they're living a healthier lifestyle, there's no real red flag there, then they don't need a specialist. Even nursing staff or physician assistants can provide care for them. It's an excellent question. Thank you, Andres. I see the comment from Cuba. I think it's excellent, and it's more related to the next presentation. So we're going to be mindful of everything that our colleagues share in the chat. And I want to encourage everybody to continue sending your questions and comments through the chat. Next, we have Eric Zuniga, and he is the very definition of a hearts champion. In fact, we have defined the hearts champion model based on Eric, and we'd like to yield the floor to him to discuss some of the key drivers and how the hearts community can learn more about the pathways. Welcome, Eric. You have the floor. Thank you very much, Angelo. Please let me know if you can hear me and if you can see my presentation. Yes, we can hear you and we can see your presentation. Very well. I'd like to first and foremost thank you for the invitation to take part in this workshop, in which we will be sharing a few ideas regarding the hypertension control drivers, but more specific related to the audits. And this is something that we all know. Cardiovascular diseases continue to be the main cause of mortality in the Americas and all over the world. We were talking about millions of deaths every year due to cardiovascular diseases. And hypertension control is very low in the Americas, 35% for women and even lower for men. And this is important, especially for those who work in primary health care, because hypertension for us is an integral care element. And this is given to the very close relationship that it has with kidney disease, with diabetes, and other cardiovascular diseases that many patients exhibit when they finally show up at a healthcare facility. Throughout this workshop, we've been commenting that in order to achieve effective control of blood pressure, there are certain necessary steps that need to be undertaken. First, have a safe and effective protocol is very important, but it's no more important than having adequate equipment and medications, proper blood pressure measurement devices, and we also have to have multidisciplinary, team-oriented units specializing in hypertension. And of course, we need proper IT and monitoring systems. But even with all of that, we cannot ensure success. So the question is, what can we do to improve controls over hypertension? So based on this, we established the Hearts Innovation Group, whereby we try to look for driving factors that are key for controlling blood pressure or hypertension. And this had the objective of progressing with the implementation, designing an integrated model for assessment, focus on healthcare facilities, and also come up with a continuous quality improvement approach to be able to foster a better service at the primary care level. So we also looked at the drivers and other factors, as well as methods to exercise better control over hypertension at the primary healthcare level. Now, we ventured into 5 very simple areas, as Andres mentioned: diagnostics, treatment, continuity of care and follow-up, systems, as well as assessment. And we also developed 8 drivers: diagnostics, adequate measurement of blood pressure, and the estimation of the cardiovascular risk. And we didn't just end there. We also came up with 17 recommendations, or rather interventions, through which we could manage some improvement over the hypertension control for many of our patients. In addition to this work, we developed a very important tool, the Hearts Scorecard, which allows us to assess each one of these drivers placing level of compliance for each one of these factors. And through this, we can have a better baseline understanding for comparative analysis related to the maturity of the intervention for a HARTS initiative in a local facility or at a regional level or in an entire nation. So in Chile, we decided to conduct a first assessment of the maturity of a HARTS program implementation. This was undertaken between March and June of last year. We had a number of members of the healthcare system in Antofagasta, Carolina, Jaula, and all of the leadership in the Antofagasta healthcare system. And we assessed all of the electronic and paper systems that related to the incoming patients to the cardiovascular program, and we looked at a period from June to September in 2021. We conducted visits to the healthcare centers and interviewed the healthcare workers, physicians, nurses, nutritionists, chemists, paramedics, and administrative officials for these healthcare centers.
What were we doing with the teams? We had an initial meeting with different indicators within a certain context. This was not a review. It was simply just a meeting to establish a baseline to be able to advance in the HARTS initiative implementation. We reviewed the data. We reviewed all the clinical registries, the histories, and then we established an improvement plan. And then we determined that all the centers should be advancing in the same direction. And this should be related to the implementation of the HARTS initiative. So in our first visit, we went to 22 health centers. We received 2,173 electronic histories or registrations, and then 919 of these registries were included in these visits. So we had to determine how we were going to present these results, how to show the factors that were being complied with in less than 50%, that's in red, between 50% and the threshold is in yellow, and fulfillment of all the program over the threshold is in green. So this is the overview that we have for the entire region. Unfortunately, this is not good. You have a lot of predominant colors, red and yellow. So that shows that in this first evaluation, this was the situation. So this is the scorecard that is important to underline. First of all, when we gave training every 6 months to measure blood pressure, there was also almost 90% of the personnel involved in this. But when we reviewed therapy, the use of combined therapy with statins and aspirin with persons with atherosclerosis was something like 97%. And we saw the implementation of these measures. We see blood pressure of 140/90, then we just register that. Follow-up aspects and teamwork and monitoring systems and evaluation systems did not reach the threshold established. So we only reached the point that we wanted to reach in 3 items that were shown in yellow in the former slide. So here's the regional results. We have a minimum score of 2 points maximum score of 6 points, and maturity index, which was just very low or less than 4 points. So the first conclusion on the first evaluation was that HEARTS was at the beginner's level of implementation, very low level of implementation. Only in the region of Antofagasta, 2 of each 10 patients that have hypertension really had the treatment. And then we had to improve this in the health center. And for that reason, we programmed several activities in the field with the medical personnel. We use the algorithm for pharmacological treatment. And then in those days, we began to show this as a good management tool for clinical management. We developed different days for checking of cardiovascular status of these patients with the people who were in charge of the cerebrovascular program at the hospitals and centers. We work with medical personnel, nursing personnel. We told them we would be back, and we told them that on our return, we would be applying and measuring things in accordance with this scorecard. These are some of the pictures taken during our first visit. These are some of our clinical offices. We have here on the right a person who is showing the HEARTS documents for implementation, and these are other meetings. Many meetings were virtually conducted, but we sent for these virtual meetings several links and several instructions just to make sure that we would send also drivers information. So we started a system for communication of results with the health centers, with the people in charge of these services in Antofagasta, and we visited the entire region. Here we are delivering materials, and to teach, we actually here in this picture are teaching people how to use the scorecard. Of course, we have to communicate the results to the local authorities. And we had a meeting with Pedro's participation, Andres' participation too. And so this was our first evaluation. And as I said, during the pandemic, we had to use this type of distribution of the participants in the centers. But we had to really see if we were advancing, if we were actually taking steps toward the place where we should be. So with that overview, then we developed the second evaluation from March to September of this year. And then we have the same participants that attended the first evaluation, and Francesca, who is a health nursing specialist. And we actually studied the registration charts, both electronic registration and paper registration. So we, this time, visited 22 centers. We actually received 2,971 clinical registries, electronic clinical registries, and 1,117 had been hospitalized because of hypertension, or actually admitted because of hypertension. So this is, just the distance from Arica to Punta Arenas. So we really spent a lot of time on the road. And when we had prepared the summary, we see this is the first chart to summarize the results. And now you see the difference. In the second, now we see that yellow and green are the predominant colors, and the red colors have diminished in the second evaluation. But even then, we have several things to consider. First of all, recommendations. As we mentioned before, in this review, 98% of the staff was trained with a certificate, and then 9% of all the devices were validated. 94% of those devices were validated. We know that these figures are better than the ones before, but they are not enough coverage yet. We have to realize that therapy is still very low, and that we see that blood pressure measurements are 140/90 in some cases. And we have to really correct this therapeutic inertia. So regarding the drivers, in the drivers, we registered improvements. In some, we reached the thresholds, and in others, we were close to it. So our work is going well. So we see minimum score 8 points, maximum 13. So we went from level 1 to a point between level 2 and level 3, which means more maturity. So is this reflective of any changes? These are the results in percentage points. Here, we are comparing December 21st, 2021 to December 2022. You see percentages, coverage 61, 64%, effective coverage 26, 27, final coverage 43, 43. But one of the centers that had the highest improvement in maturity index, we went from 64 to 72%, an improvement of coverage from 28 to 32%, and coverage from 43 to 45%. Of course, there are some areas that need improvement, substantial improvement in time, and those areas are reflected here, the evaluation of cardiovascular risk. We still have to work on the initiation of combined therapy, the work with statins, and then work with patients who already have had cardiovascular events to adjust protocols, have control in weeks 2 to 4, and then administer aspirin, consider to follow up on the cardiovascular risk, measuring of blood pressure twice, and intensification of therapy. So these 9 points are contained in what we have been talking about all morning in the clinical pathway for control of hypertension. So I agree, the clinical pathway is a very effective tool for control of blood pressure. And I would like to thank Angelo, Pedro, and Andres, and Eduardo, your invitation to participate. And I would like to leave you with some messages. And the first one is that high blood pressure is the main cause of cardiovascular disease and death. And then the effective treatment reduces the risk of cardiovascular morbidity and mortality. And the application of a scoring system allows us to know the degree of maturity for the implementation in the Hearts Initiative and to focus our efforts in the failing points. And then we have to apply the scorecard of hearts and the clinical pathway. This is not just an academic technical exercise, but it's also a very useful tool for evaluation management and continuous management within the implementation of the Hearts Initiative in the region of Antofagasta, in the region of the Americas. Thank you so much for having invited me, and I am here ready to answer your questions or comments. Thank you so much, Eric. Excellent presentation and excellent work in Antofagasta. It's really impressive what you have done to see the difference between the 2 points of evaluation. You see, when we see the results on the first chart, either we stop here or we can go ahead, and then you actually just went to a second option that were consigned in the second chart that you showed. Please stay a minute with us because we have a couple of comments here. I will begin with Cuba. Please continue to write. For the evaluation of the fulfillment of all these parameters, we really should incorporate this system in the planning for New Year. From Guatemala, it says we have a low staffing pattern, especially for diabetes. That's a barrier. The health authorities are always afraid of talking about the side effects of medicines. But then we have to also care for hypertensive patients in first level and second level to make sure that we detect the risk factors for dyslipidemia, hypertension, and diabetes. We have to really start with changes in the lifestyle. And then Victor Won says, congratulations, Eric. Which is the difference between effective coverage and coverage just by itself, and the denominators of these indicators? Yes, coverage is just how many patients with hypertension are under treatment in the population, and where the prevalence has been effective. And the effective treatment is how many people have been compensated for, and with the values compared to just the normal coverage. Thank you so much. I know that the chat is full of congratulations for all the speakers. Thank you. I would like to say that we are going to compile and consolidate all of these comments that have been made in the chat. They are really valuable. Please continue to enter your comments about the topics being presented. Now, my colleague, Libardo Rodriguez, will be talking about monitoring and evaluation, which is a very important clinical element within this quality improvement. And if you wish, please, as Libardo presents, just tell us about your efforts in monitoring and evaluation in your countries. Good morning, Angelo. Good morning. I am Libardo. I am part of the data team of the HARTS regional program, and I will be talking about the HARTS monitoring and evaluation for quality improvement. So the system was developed based on a model that took the primary healthcare center as the main unit. We are just following the clinical life and development here with patients with evaluation. Angelo has already mentioned this. All of this aiming at the improvement, continued improvement of quality. One of the main points of the HARTS initiatives is this one. This allows primary health care center to have an analytic report or module with real answers in real time. So we have access to information in a graphic way. So that way we can really speed up management and different levels. But we are interested in working on the health, the level of the health centers. But we also have improved communications among the centers to improve the learning of better practices. So with this, we can make decision-making an easier process. And then within a specific timeline, we can improve interventions to be able to continuously improve quality. All of these indicators are gathered into the system of monitoring and evaluation depending on the programmatic priorities and taking into consideration all the aspects of the HEARTS initiative implementation. And here we can identify gaps in the process of implementation. In this sense, the main objective is to try to understand the program implementation, to analyze performance in all the successful aspects and problematic aspects, and then to identify all the causes and considering that the main place of our work is the primary health center. So once we determine the cause of these problems, we can determine the modifications to improve the system. Also, it is important to notify and report good quality data. It's important to have quality data. The quality of data is the success of the implementation of any process. And then this is linked to the availability of having reliable data. Also, we have to try to understand that the quality of information facilitates to a great extent the adoption of measures to be able to have corrective actions. The information has to be 100% emphasized as quality information, taking into consideration the different variables and also taking into account the importance to be able to share this information periodically and to strengthen collaboration and teamwork. So we will start here with the evaluation of the situation, of the status evaluation. We try to understand the conditions of the health center, primary health center in this case, and all of this with this is within the HEARTS framework. We have several variables. You have structural variables, process variables, and results variables. All of these within the framework of primary health care. So the structure has to do with the workforce at primary health care level, then the access to validated patients, the access to drugs, and then in the process we have the use of the clinical gateway, the implementation of the hypertension drivers, teamwork, education, and training. Also, we have also mentioned several coverage information here. Once we have identified this, all of these variables, which are part of the conceptual framework and the HEARTS structure, we have to ask several questions of different types. Which is the size of the population cared for at our primary health care center? And then, which centers work well and do not work well? We are implementing, whether we're implementing the clinical pathway, how can we continue to improve quality? All of these questions are important because the health center has to formulate these questions. And if there's an answer that cannot be given because of lack of information, we have to work on that. So each one of these questions is related to types of these data are related to the questions. So it is essential to have a monitoring and evaluating system where we can gather all of this information within the national health system. As Angelo has said, we not only will center on the reporting part of this, but we have to really identify the different variables and variables in the different countries. So these variables all feed into all of these charts here. Each one of these modules has something really important. We have different periods for evaluation. We have the modules, the structural modules. We have a geo location and typology and demography. We have also the places, if it's one time, it's an urban or rural area and so forth. And then we have the demography. We have the structure module 2, which we see annual data per semester and per month. So we here have monthly evaluation to see the implementation of the hypertension measures. And this is what Eric mentioned before. And then we have the results module, which is also filled monthly. And we have all the control variables for hypertension. Having said that, we will now go to the system. When we know the variables for evaluation, we go to the DHIS2 system. It's a health information software. It's a platform from the web code. It's an open code, and it's one of the most used for information management in the field of health. And so this allows us to have a high number of medical registries in the different countries. And also it shows how we can have automation in an adequate way of generation of reports so that health centers can identify all of the deficiencies to be able to put into practice good measures. We also have dashboards. We have a series of dashboards, and we consider they are the most important and adequate to be able to continue with this quality improvement process. And that way we can produce systematic information that can be disseminated to all the health personnel, because this offered updates which are clear regarding to performance and maturity indices. And the main objective is to make sure that the team is involved and motivated and ready to work on continuous improvement. Here we have a screenshot of different data from the countries that have already improved this monitoring system. And here to the left, we have the processes disaggregated by sex and age. So in summary, the monitoring and evaluation system has been developed. It can be used. In fact, we are using it in the countries. And then, as Pedro said in his presentation, we're focusing this on the clinical pathway and the control of hypertension. It has been used as a DHIS2 tool, and it shows several advantages from the technical standpoint. And also we have had several problems because many of the information systems existing in the countries do not answer any questions that we have had shown in previous slides. So we really have to answer those questions and to have an information system that is more user-friendly, and so that this allows us to get to the objectives. And also we are lacking in prioritization and technical capacity to be able to implement the total implementation of the program. And then most countries really have not developed yet a plan for evaluation, and it is important to develop this plan.
Lo que tenemos hasta ahora
In basic terms, this is what we have so far in terms of the system implementation process with a focus on continuous quality improvement. And we wanted to continuously leave the doors open for any recommendation or suggestion. Thank you. Thank you, Eduardo. And please don't leave us yet. We have a couple of questions in the chat. One, if in the countries we have the intent to follow with monitoring drivers, can we use the HDIS2 for this? And what would be the process or requirement? Yes, of course. In fact, some of the countries are not using all the modules. In my presentations, I try to focus less on the systems and more on the variables. This is a step-by-step process. You can begin with a few variables and just some modules and continue with the process. In terms of the specific question, most of the variables that we collected for the execution of these drivers are collected on a 6-month basis. A few of them are collected on a monthly basis, and we can combine some of the variables and you can start building the framework and improve it over time as long as you include and enter more and more information. But of course, you can start with any of the modules. Wonderful. Second question. What happens if in my country I already have an operating system? Maybe it's not perfect, but we can still use it. Is this compatible with the HDIS2 system? Yes, we have 3 implementation strategies in mind. One is the healthcare general system. If you don't have any information system, then you can capture or enter your information on this platform. The second one is more geared to the less than modern systems that are not up to date with technology. And then they could take their information systems and load up the HDIS2. Now, what are the benefits of this? Well, they could have the visualization of all of the data and use information collected in other healthcare centers. And for those who already have more advanced technology and have the capability and wherewithal to communicate with other systems, we can then move towards interoperability. And so the country information systems that are connected through this network can report information and work in a joint fashion to collect information and data from the various healthcare centers. As I stated earlier, we're not focusing our efforts in such a way that the healthcare facility needs to have all this information. They can start building it up on their own. 2 more questions, Olivar. Shanna asks, what happens after this? If we decide to adopt this, do we start having meetings? What would be the next steps for the countries to take to set up a system like this? I think one of the key elements here is to become more visible and start reaching out to countries to see how we can get started. We have an implementation process that's not written in stone. Each country needs to come up with their own plan, given that they all operate in a different way. But as far as our implementation, we ask for basic information that has to do with the structure and location of the healthcare centers, so we can enter all that information in the IT system. The only thing we ask is that basic information. After that, we work with the country to generate and write an implementation plan. Now, what's contained in that? Well, it would take the trainers of the trainers to start managing at a regional level and down to the teams and to the healthcare center facility. They can provide the training, and that's how you can integrate all of this, briefly speaking. And I'd like to ask you, while we move on to other things, that you answer some of the questions that have been directed at you in the chat, because we don't have that much time to continue responding to these questions. Thank you, Libardo. Let's go to the second key moment of today's activities, the presentation of the second document related to clinical instruments. And for that, we will yield the floor again to Andres Rosende. You have the floor, Andres.
Muy bien. Gracias, Angelo. Bueno, mi presentación
Thank
ahora va a
you,
ser
Angelo. My presentation this time will be very brief.
lo mismo.
It's really going to
Pueden ver resultados
come back to the same things. You can see everything summarized in this slide,
tradicional.
and this is the traditional healthcare model, and this is the healthcare framework that we have, and we can't do any more. This cannot provide any more. Getting back to the issue, this isn't an issue related to scarcity of resources, poor countries. It's really more an issue of poor management, which is a problem the world over. Now, most of the patient flow under this traditional model or paradigm is focused towards specialized treatment or care. This is extremely prevalent, and it's actually increasing and on the rise. We talk about this silent pandemic of sorts. And so these are factors that are being standardized more and more in the system. So if the traditional paradigm of care is maintained, the situation will not only maintain itself, but rather worsen. That's why Hartz proposes a complete paradigm change that is completely contrary to the traditional healthcare model. And that's why we are undertaking this regional workshop on continuous quality improvement. And so if I have a clear-cut objective of where I want to be in a set amount of time, if I know where I am right now and I understand the concrete actions that I need to implement, then I need the adequate tools to be able to execute my plan. And the joint initiative with the work carried out by all of you in the countries, because this is a community of practice, what we've seen is that there's been a development in recent years of different clinical instruments that are, for lack of a better word, dispersed all over the place. And in this compendium, what we sought to do was bring all of that together in a single place, because the problem is no longer the lack of instruments or the lack of evidence. The problem is that it's too widespread, and we haven't come up with a practical way to use all those resources that we have available to us. So we want this protocol to be the tip of the arrow, and we won't be able to deal with this global CVD pandemic by expecting healthcare teams to use 200-page clinical guidelines, which is what used to happen not that long ago. So in this particular document, we've published guidelines for internationally standardized hypertension control protocols. And this is geared towards hypertension specifically. So we've attempted an integrative approach to all of this, and this is what we wanted to present today. So this compendium of clinical tools will include old favorites, but these are summarized in a very practical way into a very practical tool. You can easily print these materials, and in fact, we're looking at a modular format that is, in its totality, the document is a complete package of interventions. But if you need to print tool number 3, for example, let's say you want a list to verify what blood pressure measuring devices are validated or not, or some other tool, or tool number 8 that relates to monitoring and evaluation system for quality improvement. So this is designed from the perspective of practicality, and it's completely contrary to the traditional practices that we've had in place for a very, very long time. So the first page relates to the current urgent state of affairs and where we need to go. Why? Because the issue surrounding hypertension is an issue that is urgent. It also highlights the most outstanding problems and issues in this paradigm and what we can see as a potential solution. Instrument number 2 shows us the up-to-date poster of how to take appropriate blood pressure measurements that are accurate with patients. And this has been reviewed and revised until very recently. Number 3 offers resources to verify if a blood pressure measuring device is clinically validated or not. Instrument number 4 offers the logic behind the categorization process for hypertension. And number 5 shows us the WHO guidelines for the pharmacological treatment of hypertension in adults. And it gears most of the text to the attachments, and it summarizes all the most relevant information contained in these other pages. And so we've reduced this to 5 questions that can be used at the clinical level. The same relates to the drivers for hypertension control, as well as the recommended interventions. We see the 8 drivers and the 5 different areas on the left side column. One thing that I wanted to mention is that the base for each clinical tool will have the geographical reference that supports it, as well as a link that will tell you or take you directly to the complete text, so that anybody who wants to study the information can access the information very easily. Tool number 7 is the main HEARTS implementation instrument, and it refers to the clinical pathways. And finally, tool number 8 relates to monitoring and evaluation system for quality improvement. This is the engine behind the monitoring strategy. And lastly, something that has been very popular in the different countries is number 9, which relates to the coursework as well as HEARTS training and education resources that provide education and training on how to implement a HEARTS clinical pathway. We have individualized access to each one of these modules and courses, and they are available to anybody who wants to use them. So we are in a pretty advanced stage in the production and management of the document, and we will be making it available to all of you as soon as possible. Angelo? Thank you, Andres. Excellent. This is a marvelous document. As Andres was saying, you can read it individually, page by page, or you can read the whole thing. It'll soon be published and be made available to everyone who's interested in receiving it. We'll be talking about translating it into other languages and other issues. Thank you, Andres. Moving on to Cynthia to talk about measuring blood pressure, a very relevant subject. And without nothing further, Cynthia, you have the floor. Thank you, Angelo. Yanni, can you show me the slides, please?
Gracias. El primer, por favor.
Thank you. The first one, please. Good afternoon. Good morning to all of you, wherever you are. I am going to speak in English.
Good afternoon, good morning. It's a pleasure to be participating in this quality improvement workshop with all of you. Next slide, please. I'll be talking about these interventions that are the first ones listed in the table that my colleague Andres Rosente presented. They refer to the accuracy of blood pressure measurement, which is a component of diagnosis, the other being CVD risk assessment. Next slide, please. To start talking about BP measurement, I have a simple question. How can one start hypertension treatment without being sure that the measurement is accurate, or in other words, that the patient has or doesn't have hypertension? Therefore, this is a question of patient safety at the individual level, and at the populational level is a question of effective use of resources. And both point to quality of hypertension control. I have seen BP measurement done incorrectly many times. And I cannot even remember here in the US where I live, having the experience of having my blood pressure measured correctly here in health services, where it's supposed to be a high quality health system. Yet, despite being a quality improvement driver, it's often relegated to a second plan. We talk much about medication and other interventions, but not about the measurement so much. So this is why we stress, as hearts, we stress this point so much. Next slide, please. So going back to that table, here are listed the 3 requirements for accuracy of blood pressure measurement. Training every 6 months by the health workers or health professionals measuring blood pressure. Use of a standardized measurement protocol and use of a validated automated BP measurement devices. This means that accurate measurement involves not only the health professional in charge of measurement, but also the patient, the person in charge of organizing the health facility, the clinical workflow, the academia responsible for training, and the officers responsible for procurement of BP measuring devices. Therefore, it's a collective effort. Next slide, please. So we start with the first requirement for correct BP measurement. It does observe that the frequency of training affects the way health professionals measure BP. This is why the requirement of repeated training, of frequent training. With time, we know that people get into certain habits and try to simplify or do it in a very short time. So it's helpful to be reminded of what the good practices are. And for that, we have an excellent virtual course free of charge, and that takes very little time. And my colleague, Jenny Rodriguez, will talk more about these virtual courses later. The second intervention of this driver is the use of a standardized protocol, which is key. And the HEARS protocol, that's part of clinical pathway, includes, among others, the setting, which should be a quiet place, chair and table to rest the arm. Believe me, I've been, my blood pressure has been measured with my arm handling my legs too, because there was no chair or table. Life patient preparation, such as resting for 5 minutes, not having caffeine or alcohol 30 minutes prior to measurement, and not sitting with the leg crossed, and so on. So having a poster in the facility helps the patients to understand the correct technique and be prepared for next time. With a cup size, it's often said that one size fits all, but that's not correct. Here, with the obesity rates increasing in the region, we need to have adequate size to measure all the individuals correctly, since this can have an impact on the numbers and repeated measurement, repeating after 30 seconds and obtaining average. We have all these elements have been shown to influence accuracy. For example, studies showed difference from between the first and second measurement, which can be significant and affect the decision to treat or not a patient. And here it's one, it's shown. Next slide, Yemi. No, the next one, yes, talking about this one. Next one, please. Okay, thank you. So the use of validated automated blood pressure measuring device, that's the third intervention or requirement. Then we talk about this component a bit more. Next slide, please. Now the question, why automate it? There is evidence that unerroid devices in primary health care can lead to inaccurate results. Several studies have shown the discrepancy between measurements by unerroid and automated devices. And here we just have 3 examples, but there are more. And why this discrepancy? Factors might include the need of a specialized training to use unerroid devices, difficulty in hearing the sounds, the correct sounds in noisy environments, the need to have the unerroid device calibrated regularly and maintained. And we know that the majority of these devices, we talk about 90% or more, are not maintained. So I mention this because many governments are still procuring unerroid devices, even through regional office, Barros Regional Office. And next slide, please. Here we have another question, why validate it? Then we have the scientific evidence again, and I have some just picture of some of the publications, some papers showing that the validated devices are more likely to be accurate. And this is why WHO has recommended the use of automated device. You can see here the publication, Yeni. This is the publication by WHO from 2020 recommending the use of automated validated device in primary health care. And this is what Hearts in the Americas is recommending and supporting. And even with all these recommendations, and like Dr. Duniz mentioned, most devices in the market are not validated. 80% or 85% in the region and around the world are not validated. So very likely not to be inaccurate. Next slide, please. Now we talk so much about validation. So what is validation? It's the clinical testing of a device using a protocol accepted by professional societies and conducted by independent investigators, not by the industry, with results published in peer-reviewed scientific journals. I emphasize often that validation is not calibration and that automated devices do not need to be calibrated, because I get the question often. They do not need to be calibrated. They need to be maintained. The cost might need to be changed, but they don't need calibration. Next slide, please. So now we know it might not be easy to find out which ones are validated, because many of these have labels, or the box, the packaging says that they are very accurate, and in fact they're not. So how we find out if they are validated or not? So in our website, there is we have this document with the web links to all these devices that are validated. So we have to get the model, get the brand, and go in one of those sites listed to the left and try to find out if they are in that list, in those listings. And to the right, we have this article that you can find also in our webpage that says how to check that the blood pressure monitor has been properly tested for accuracy. And to the right, we have a list that Hearts in America developed. It's not in the website, but we can give to you by email. This list includes models. It's not exhaustive, it includes several models that can be found in the Latin American and Caribbean market. And have we looked to see if they are validated? So the list includes only those that are validated, and many of those have been already analyzed by the procurement office of PAHO. And so they have also verified other quality assurance components. And we can provide this, we just request by email, and we'll send, I put my email in the chat. Next slide, please. But now we have the ultimate goal of Hearts is to have robust regulations implemented to avoid import of inaccurate devices or non-validated devices. This is really what we aim at. We know it takes time, involve other government sectors, not necessarily the Ministry of Health, involve economy, trade, all that. But we really need to push for regulations so that no registration for sale is granted to inaccurate devices, and that we don't find those devices in the pharmacy around the corner, as it's the case now. We have observed a lot of progress in procurement and the regulation of procurement of validated BP devices by health authorities. But we're still a long way in ensuring that all devices, including those using home monitoring, are of high quality. So the goal for 2024 and beyond is to advance in the development of regulations. And we can support you in this process. That's what I had to say today. Thank you very much.
Excelente, Cynthia. Muchas gracias.
Excellent, Cynthia. Thank you so much for your presentation and for the important elements that have to be considered regarding these devices. Questions about the validated brands. You have actually responded this, but you offer your email for any specific doubts, because this all depends on each country. And I invite you to please go ahead and make other send other questions in the chat. If we cannot cover them today, we can just cover them tomorrow. But I would like to underline the first part, which is about the importance of the training courses, and Jenny will review the available training courses. And with this, we will be closing today's session.
Thank you, Angelo. Let me know if you can see my presentation. Yes? Okay. Without further delay, given that we're all pretty tired, we will move on to the last point on today's agenda. And this relates to the Hearts virtual courses that are available. We saw fit to create this necessary training tool so that healthcare workers could undertake the implementation of this initiative, which really encompasses a number of different components. But in order to address different components, we need healthcare workers and administrators that are committed, as well as properly trained. I want to talk about two virtual courses that we just opened this year in 2023 during the first quarter of the year. The first course relates to supporting primary healthcare teams to use BP medications effectively. This is a course that's available in English, and will be available very soon, in a mere few weeks, in Spanish as well. This is a course that was developed based on what we've been talking about throughout the course of today, and that is that we cannot close this session without pointing out that cardiovascular diseases are the main cause of mortality all over the world. And hypertension is the leading cause of cardiovascular risk. The WHO decided to address something new, something that hadn't been addressed before, and the Hearts Initiative in the Americas decided to put into practice and support the countries to develop the hypertension management protocols in those countries that didn't have one. And we developed the guidelines for the available protocols and that are now available through the clinical pathways in the Hearts program. Through this, the WHO pointed out the importance of using combined medications and combining two medications in a single pill of the 4 hypertension medications, which include the ACIS, ARB, CCBs, and thiazide diuretics. And it also developed guidelines related to the need to test and monitor patients, especially as regards any adverse events after treatment. And the use of low-dose combined medications do mitigate these adverse reactions or events, or potential adverse events. And of course, we know that they offer other numerous benefits, such as their aggregated positive effect, better adherence to treatment. It also has better economic impacts related to healthcare. It reduces the need for the patient to go back to the healthcare facility on a more frequent basis. And everything mentioned here is contained in this course regarding the effective use of hypertension medications. And we put all of this together in a course that has 6 modules that are very specific. The first one gives an overview on antihypertensive medications, which includes some of the medications that I just mentioned. And it also addresses other modules that stem from the needs disclosed by many of you in the Hearts community. Module 5 specifically addresses BP drugs and erectile dysfunction and other antihypertensive medications. It sought to break down certain myths, and the modules on spironolactone and whether or not it should or should not be used. And we've seen some resistance issues to some hypertension medications, and we need to be able to address these potential adverse effects. So this is a key course that needs to be taken by healthcare personnel to be able to undertake their day-to-day activities. In addition to these courses, which are available to anyone who wants them 24/7, and these are set up in a self-paced modality or self-administered. You can start and stop these courses or modules whenever you see fit. The coursework is recommended for all the members involved in the primary healthcare arena that have authority to prescribe and treat hypertensive patients. And it's also recommended for medical students and medical students in their last year of their degree program, because they will become healthcare providers in the short term, and they need to be brought up to date with regard to these issues. The other course that we launched very recently and that we offer through virtual platforms is the home blood pressure monitoring course. And this has been very novel because it's the first course that we have to support and empower patients with regard to self-care. It's something that stemmed from a need that was disclosed by many of you in the different countries to develop something that would empower patients to take some ownership in their own care. And we've seen some really important advances with this program. The course highlights the significance of increased blood pressure, the importance of proper BP measurement technique. It shows the step-by-step process to properly measure blood pressure at home. It also discloses the factors that can lead to measurement error. And then it also covers how to interpret home BP numbers, including when to follow up with the patient and when to seek immediate action. And all this as a function of the measurements recorded by them at home. This is a course that was developed with patients in mind and with the general public in mind who may have a confirmed diagnosis of hypertension. But it's a course designed to be taken by healthcare workers so that they can in turn educate their patients and create greater awareness for patients that they have some control over their own care. It also considers community workers that need more tools to educate their patients, especially given that we know that in many of these rural communities, as it happens in many Latin American countries and the world over, they tend to be at lower income areas. And in those areas, most people don't even have access to a physician. And it's a community worker who's in charge of providing this type of care. So it's necessary for us to empower these patients. They need to learn how to measure their own blood pressure. And it's a one single module course that's very brief. It lasts less than 30 minutes. It has few components. It's highly illustrative. And it addresses how to measure blood pressure in a very simple way, and it includes different links to other content. It has the illustrative forms or the illustrated format that describes the step-by-step protocol, and the patient can then record their own blood pressure measurements that they can subsequently share with their healthcare provider. Many organizations at the global level were involved in the development of this course, and it's based on very solid science, and it's extremely well designed. In this last slide, I wanted to show you the other 4 courses that we have available on the virtual platform in different languages. One mentioned by Cynthia regarding how to properly measure your blood pressure. And this is firmly contained in the list of drivers for the heart's clinical pathway. This is absolutely essential, especially for all healthcare providers and even patients, because we cannot afford to lose a patient for lack of treatment, and certainly not for mistreatment. We also have another course on proper management of blood pressure, especially for high cardiovascular risk patients. This includes clinical practices as well as other principles in the heart's clinical pathway, and it uses the heart's module that is also applicable to diabetes. We have patients that are undergoing dialysis and other cardiovascular diseases. It's a course that is 100% clinical and extremely useful. We also have the course on the blood pressure drivers, which is not just a course for managers or healthcare providers, which is something that was asked before. It was designed to be digested by clinical staff because clinicians need to familiarize themselves with all of these drivers that are so important to ensure that a hypertension control program achieves some measure of success. And lastly, the oldest course that we have relates to the heart's technical package for primary healthcare facilities. It addresses each one of the heart's modules one by one that were published in 2017, and it's a course that continues to be relevant today, though we do need to update a couple of the modules. We'll be undergoing that process in the next few months, hopefully by the end of the first quarter of 2024. Nevertheless, the course is still very relevant and valuable for healthcare workers that need to learn the necessary practices to be able to do a proper hearts program implementation. That's all I have, and this is the last slide. I'm happy to answer any questions. Thank you for your attention. Thank you very much, Jenny. It's a very complete list. We have a brief question from Diana. When will these courses be available in Spanish? Well, that's exactly what I was asking the technician. I'm not willing to commit to a date, but he was telling me that the at-home BP measurement course will be the quickest one, less than 2 weeks, because it's a much shorter module, and that will be available in Spanish in a couple of weeks. The other courses will take much more time because there's a waiting list of 3 courses that need to be translated, but I've been told that some of this will be available before December 20th. So it's very soon. That's wonderful. Thank you, Jenny, for the list. I want to echo Maria's words. It's important for healthcare workers and service providers, everyone in essence, to understand all of these practices and all of the elements involved in the Heart's Clinical Pathways program. Thanks to all of the team members. Thanks to everybody who joined us today. We will meet tomorrow at the same time, same channel, and we look forward to seeing you. And if you liked today's activities, tomorrow will be even better because we will be hearing about the national experiences in the different countries, Cuba, Dominican Republic, Santa Lucia, and El Salvador, sharing their success stories related to everything that we discussed today. Additionally, we will have a second part on performance assessment at the regional level. We will have a keynote speaker, Mr. Onasco César Garcia from PAHO, who will be discussing some quality issues, and we will define the priorities for 2024 and close with some group work to learn how we can do our work in a much more effective way in our respective countries. For most of you, it's good afternoon, so I wish you, oh, excuse me, wait. Jenny, you have the last word here. Yes, I just wanted to inform you that the link for tomorrow, I know that you all have the agenda, but the link for tomorrow is different. Remember, it's a separate link, and once we are done, we will have the separate group sessions, and each group will be connecting to a separate and distinct link. So we will be sending these different links for each group tomorrow. So just be aware of that and be mindful of your emails so that you can have access to those links. Very well. Make sure you are keeping track of your emails so you can get the link for tomorrow. Thank you very much, and we'll see you all tomorrow.